Okay, good morning, everyone, and thank you for joining us today. A short disclaimer, the information presented here is for the purpose of informing the board. The views expressed do not necessarily reflect the views of the board or any board member. We are recording today's session. You will be able to access it on our website, ssab.gov. Questions and comments are welcomed and encouraged and can be submitted via the Zoom Q&A function or email to us at events@ssab.gov. You can also tweet us using our handle at @ssabgov. Feedback is also welcome and can be sent via email to events@ssab.gov. And with that, I will hand it over to our board chair, Bob Junda.
Good morning, and welcome to the Social Security Advisory Board's event on the future of mortality, disability, and work, helping to inform the trust fund projections. I'm Bob Junda, the board chair. I'm talking to you this morning from my home state of Oregon. And just a brief introduction about the board. The Social Security Independence and Program Improvements Act of 1994, a mouthful, established a bipartisan Social Security Advisory Board composed of 7 board members appointed by Congress and the White House. Supported by a small professional staff, the board provides advice and recommendations to the President, Congress, and the Commissioner of Social Security on matters related to the Social Security and supplemental security income programs and policies. And now I'd like to turn it over to my fellow board members to introduce themselves. First, Nancy. Are you there?
I am. Sorry about that, Bob.
No problem.
Thank you so much. Yes, we are all excited about today's program, and thank everyone who's joining us from, I believe, literally around the world. As Bob said, I'm Nancy Altman, a member of the board, and I'm here in Washington, D.C. And with that, I'll turn it over to Jagadish.
Thank you, Nancy. My name is Jagadish Gokhale, a member of the board. I am zooming in today from Philadelphia, Pennsylvania. I work at the Penn Wharton Budget Model at the University of Pennsylvania, and I look forward to the discussion today, and I welcome all the panelists and attendees. Thank you very much.
And I'll close us out. I'm the newest member of the board, Amy Stewart, based in Washington, D.C.
Thank you. The annual report on the financial status of the Social Security trust funds garners significant interest in the media and political arenas. It has implications for millions of current and future retirees, their survivors, their families, and individuals with disabilities. We would like to share highlights from last year's trustees report as a level set for today's conversations. The Old Age Survivors Insurance, OASI Trust Fund will be able to pay 100% of total scheduled benefits until 2033, 1 year earlier than reported last year. At that time, the fund's reserves will become depleted and continuing program income will be sufficient to pay only 77% of scheduled benefits. The Disability Insurance, or DI Trust Fund, is projected to be able to pay 100% of total scheduled benefits through at least 2097, the last year of this report's projection period. By comparison, last year's report projected that the DI Trust Fund would be able to pay scheduled benefits through at least 2096, the last year of that report's projected period. If the OASI Trust Fund and the DI Trust Fund projections are added together, the resulting projected fund, or designated OASDI, would be able to pay 100% of total scheduled benefits until 2034, 1 year earlier than reported last year. At that time, the projected fund's reserves will become depleted, and continuing total fund income will be sufficient to pay 80% of scheduled benefits. The two funds could not actually be combined unless there was a change in the law, but the combined projection of the two funds is frequently used to indicate the overall status of the Social Security program. The objective of this event is to hear from a diverse panel of experts and discuss the implications of current knowledge on mortality, disability, and work to help inform the trust fund assumptions. We are pleased to have Steve Goss, Social Security's Chief Actuary, Karen Glenn, Deputy Chief Actuary, and Mike Stevens, Acting Deputy Chief Actuary, to join us today. The bios of all of our distinguished experts are available on the SSAB website at ssab.gov, and we extend our sincere appreciation to each of them for their participation. We look forward to the robust discussion ahead. And with that, I'll pass it along to Emma.
Thank you, Bob. We have a bit larger panel for mortality, so we'll get started a few minutes before 10. Good morning. My name is Emma Tatum. I'm a lead policy analyst here at the board, and I'm excited to be moderating this morning's session on the future of mortality. Questions and comments are encouraged throughout the discussion and can be submitted through the Zoom Q&A box or by emailing us at events@ssab.gov. We are recording today's session and we'll post it to our website following the event. This panel will discuss expectations for future mortality trends in light of issues such as COVID-19 and possible future pandemics, rising deaths from drugs, suicide, and chronic liver disease, sometimes referred to as deaths of despair, and rising pediatric mortality. How long people will live to pay into and receive Social Security in the future is a key consideration for OASDI program projections. We are so fortunate to have such an esteemed panel of experts with us to discuss this topic today. I will introduce them very briefly before we begin. Their complete bios are available on our website at www.ssab.gov if you'd like to read more about them. Robert Anderson is Chief of the Mortality Statistics Branch at the National Center for Health Statistics at the Centers for Disease Control and Prevention. He oversees and is responsible for the production, analysis, and dissemination of national mortality statistics. He has also worked on issues related to disease classification, improvements in data quality, especially regarding cause of death reporting, and most recently, quantifying the effect of the COVID-19 pandemic on mortality in the United States. David Cutler is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University and holds secondary appointments at the Kennedy School of Government and the School of Public Health. His expertise is in health and public economics and economic demography. Stephen Goss has been Social Security's Chief Actuary since 2001. He has worked in areas related to health and long-term care insurance and pension, disability, and survivor protection. Karen Glenn is SSA's Deputy Chief Actuary for long-range actuarial estimates. She is responsible for the demographic and economic assumptions that underlie the 75-year estimates of the cost of the Social Security program. Christopher Murray is the Director of the Institute for Health Metrics and Evaluation and Professor and Chair of Health Metrics Sciences at the University of Washington. He is a physician and health economist who leads the Global Burden of Disease, Injuries, and Risk Factors enterprise, which quantifies the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geography over time. Christopher Room is a professor of public policy and economics at the University of Virginia. His research has focused on excess deaths due to the COVID-19 pandemic, drug poisoning deaths in the United States, the relationship between macroeconomic conditions and health, the determinants of health and risky behaviors, and the causes and consequences of alcohol and illegal drug policies. And last but certainly not least, Stephen Wolf is the Director Emeritus of the Center on Society and Health at Virginia Commonwealth University, where he is Professor of Family Medicine and Population Health and holds the C. Kenneth and Diane Wright Distinguished Chair in Population Health and Health Equity. Wolf is also a clinical epidemiologist trained in preventive medicine and public health. He is board certified in family medicine and in preventive medicine and public health. Thank you all again for being with us today. I will now turn it over to Steve and Karen for their opening presentation.
Thank you very much, Emma. Hi, Steve Goss here. Just want to first of all say thank you so much to the members of the board for sponsoring this and your amazing, wonderful professional staff who've done all the work in getting all of this set up. This is fantastic. This is going to be extremely helpful for us and our office, our actuarial office at SSA, and for all of the members of the Social Security and Medicare boards of trustees and all of their staff. So if we might start just jumping on here to the mortality section, which is our topic of the moment. Could you please flip to the next slide? Yes, and one more beyond that, please. So we're going to be talking about mortality. I think everybody knows here that the financing of Social Security is extremely tied to the age distribution of the population. Fertility is a major component of that, but mortality is also extremely important. You can see on these slides here is an indication of what has happened with the age sex-adjusted mortality rate in the United States throughout the 20th century and so far into the 21st. It has been quite an interesting period. We had tremendous improvement in mortality through the 20th century. The first part of it, a lot of it was at very young ages, infant mortality, which is really important. In the latter half of the century, we've had some wonderful improvements after World War II, bringing antibiotics to the population and later cardiovascular. So we've had a long ride. You can see here on the right-hand slide, which is these numbers on a basis that is not the normal, but is shown to you such that you can see the actual rate of decline is sort of indicated relatively by just looking at the sort of the slope of the lines. And the key thing here is that in the 21st century, especially over the last 10 or 15 years, mortality improvement has really slowed down quite a bit. So on the next slide, please, we can see something brought from our good friend and colleague, Bob Anderson, who will be following Karen and myself in this discussion this morning. A slide that he has put together based on the wonderful material they put together at CDC and CHS, because we look very, very careful at death rates, not just overall, but by cause of deaths. This really gives us a good indication of what has been happening so far. You can see since mid-century, 1950, that heart disease has been the driver of mortality improvement. It's been quite remarkable. However, in the very most recent period, you can see heart disease has not been improving a lot, and some of the other areas like unintentional injury have been going the other direction. So really our big question is, where are we going in the future? The past is prologue, but where we're going in the future is really the big question. That's why we're so happy to have the group of panelists that the advisory board's panel has put together for us today. So I think Karen's going to talk a little bit about the next slide.
Great. Thank you very much, Steve. And hello, everyone. We're really excited to be here today and have this discussion. So on this slide, this is just another way of looking at the trends in mortality. These are what are called survival curves. And each line in these graphs is for a different calendar year. We've got a panel on the left for men and a panel on the right for women. And what this shows you is starting at age 65, the fraction of people who will be still alive at each successive age. So for example, I know these pictures are pretty small, but if you look at the graph for men, using 1900 death rates, which is the line at the very bottom, about 30% of 65-year-old men would live to age 80. By the time we get to 2019, which is the line at the top, we've got about 70% of those 65-year-old men would live to age 80. So what you can see is that people have been living longer, similar pattern for women. But one interesting thing to note here is that the maximum lifespan has remained relatively stable across these years. It's somewhere in the range of 110 to 120 years. So if these trends continue, we'll see that these graphs look more and more like a rectangle. In other words, we'll see higher and higher percentages going out to older ages, and then a very steep drop off. That's why we call this rectangularizing. So the question for us is really, will these trends continue, or will there be some major medical breakthroughs in future years? Next slide, please. All right, now digging in a little deeper to some of the factors we think about. First one here is obesity. The graph you see here is courtesy of Sam Preston, who's a researcher at the University of Pennsylvania. It is a few years old. You'll see we got this from Sam in 2010, but the concepts are really still valid. What this graph shows is the percent of people who are considered obese by 4 different age groups. That's each one of the lines on the graph. And going through time, beginning in 1971 all the way through 2005, 2006. And what you can see is the clear progression to higher levels of obesity through time for all of these age groups. And one thing that's really important to think about is that the health effects of obesity tend to be most evident for those who have been obese for a long period of time. So really thinking about those cumulative effects on the body of obesity. This is really becoming a more and more important factor as obesity continues to increase at younger ages. So again, this is going to be a common theme. Will these trends continue, or will there be changes in the future? Next slide, please. Emma mentioned in the intro deaths of despair. And I know this graph is a little bit overwhelming, but what we are showing here is some of the specific causes of death that fall into that bucket. So, for example, we've got suicides, drug use, alcohol poisoning, split into very specific categories that we get from the CDC. These are the rates of death for the population under age 65. So note that it is the younger age group. Going from 1999 all the way to 2021. So a few things jump out on this graph. The magenta line that you see jumping way up near the end of the graph, that is other synthetic narcotic poisoning. So you can think of that mainly as fentanyl. Obviously, that's been increasing a lot in recent years. The light green, somewhere near the middle of the slide, that's heroin, which has actually declined a bit in recent years, but it is well more than offset by the increase in fentanyl. Near the top, there's a darker red line. That's alcoholic liver disease and cirrhosis. You'll note there it increased significantly in 2020 and 2021, as did that light blue line, which is other unspecified drug poisoning. These may be pandemic effects. There were a lot of stories of people, living by themselves and having issues during the pandemic. So these may or may not be directly related to the pandemic. One thing not shown here, but it's more in the literature about these deaths of despair, is that these deaths tend to be among white adults in rural areas, those with relatively low education and low income. Again, will these trends continue? Other countries are not seeing similar patterns, so this is pretty unique to the United States. With that, I think I will turn it back to Steve for the next slide.
Thank you very much, Karen. In fact, could we just bop back to slide number 6 just for one moment? Just want to share with you a little bit of the perspective on how discussions like we're having today are so very useful. Back in 2011, when Sam Preston, on slide 6, please. Yeah. Slide 6, we're getting there. That's the obesity slide. One more forward, please, to slide 6. There we go. Okay, when Sam Preston presented this to us back in 2011, he said this is quite interesting because in the literature, everybody was wondering why are we not seeing increases in death rates related to obesity for people over 65 as we were getting into the early 2000s. And collectively, we all were pondering this and realized that maybe it is just like with smoking and many other things that are not good for us. It's if you are experiencing that negative factor throughout life or for a long period of time, there's a cumulative effect. And what this showed us was that at the time in the early 2000s, the bulk of people who were over age 65 that were obese had not been lifelong obese. So that helped explain it. So the kind of discussion we're having today is extremely helpful. So if we could jump forward now, please, to slide number 8, a couple forward. Great. Okay, so one of the things, obviously, that the board we all are very interested in is the most recent COVID-19 pandemic and pandemics of that sort. You can see on this graph on the left panel where we first of all have this flattening, and this is for age sex-adjusted death rates for all ages, the flattening of our mortality line to having much less improvement starting around 2009 or 10. And really real deceleration and improvement in mortality for many reasons. But then you can see the burst that we had in 2020, 2021, even in 2022 for where we have been in mortality overall, obviously associated with the pandemic. Now you can see that we have been projecting back in the yellow and blue lines back in 2014 and the 2017 trustees reports, continued improvement in mortality, which simply had not been realized even through 2019. And now with the effect of the pandemic, this is not a good thing. One of the gigantic questions is how much longer will this pandemic persist? We know the virus has not gone away. It's in fact over the last month or two been coming back somewhat with high vaccination rates. We're seeing not as bad an impact as we had earlier in the pandemic, but the virus has not gone away. And of course, one of the other things we're really concerned about is sometimes referred to as long COVID, or the World Health Organization fortunately calls it post-COVID conditions. And we know that this will be affecting us into the long-term future. One of the gigantic questions is people who have been exposed to the period of COVID-19 and maybe even infected but survived. What will that do to their longevity expectations in the future? Might some people who might have lived to 90 only live to 88 or 85? We're expecting that there will be some impact of that, unfortunately. One interesting item is you can see on the right-hand panel here, there has been the question from the very beginning. We knew that we would be losing some people to earlier death in the pandemic, which we certainly did. It's well over 1 million, most of which are over 65. And we know that these are likely to be people who would have died relatively soon anyway. So there's a question of whether or not we'll have selective mortality, leaving a healthier, less likely to die soon population because of the people that we have lost. On the other hand, we have post-COVID conditions that will be leading to some additional compromise for those people who lived through the COVID period but survived it. So we have been assuming that those two factors would about balance out. You can see here, based on some good material from CDC, thanks again, Bob Anderson, that you can see what we've shown here is that through the period early 2000 through most of 2023, you can see the black line is showing the elevation or the relationship of age sex adjusted mortality rates compared to the rates in the same period, the same calendar quarter of 2019. To see have we made progress relative to 2019. Obviously in the pandemic, we have not. But the perhaps more interesting line is the red line. If we look at deaths through this period of the pandemic, excluding deaths attributed to COVID, we can see that across in total, all of the causes of death, excluding COVID, actually still led to death rates through this period on age sex adjusted basis, elevated above the 2019 levels. So rather than seeing an improvement, which we normally expect to have on a steady basis year to year, we see that we have unfortunately not achieved that through at least 2022. So on the next slide, just a quick rundown of some of the things we're really wondering about and looking very much to hearing more from our panelists today. We're going to be paying very close attention and looking forward to discussion after. Can we expect major breakthroughs in cancer, dementia, reduction in violence in the future? That would be nice, but it may not be as easy as cardiovascular in the last century. How about COVID-19, post-COVID conditions? And how about the frequency of future pandemics with the shrunken world that we are now living in? How about obesity, as Karen mentioned, and deaths of despair? Will these be continuing at current levels where they get worse, or will we make progress against these? One thing that everybody is aware of is health spending in this country rose dramatically after Medicare and Medicaid came in. We've risen from what, 3% to close to 20% of GDP expended on healthcare. We cannot continue increasing healthcare spending at that kind of rate. Deceleration will occur. What effect will that have on future mortality rates? And finally, we know that we have an aging population. We have climate change. All of these will be straining resources. So as we have a shrinking share of our overall population, adult population and population as a whole being in the prime working ages, will that even put pressure on us in terms of having enough healthcare workers to be able to properly take care of in the way that we would want to folks at higher ages? So with that, I think we stop and we pass it on, Emma, to you and to our wonderful panelists that you have pulled together for today. Thank you.
Thank you, Steve and Karen. That provides a wonderful setup to the remainder of the conversation. Next, we'll hear opening remarks from each of our panelists, starting with Bob Anderson.
Okay, good morning. I really appreciate the intro that Karen and Steve provided. I think it provides some important context to certainly to what I'm going to say, and I'm going to just talk just a little bit about what we're seeing at NCHS with regard to mortality patterns briefly, and then just share some thoughts about forecasting future mortality and some of the challenges that I think that we face. Next slide, please. Here I've got excess deaths by week, and I have the data here from 2017 through August 5th, the week ending August 5th. Just a little context as to what you're seeing here. The dotted lines represent expected deaths. The blue dotted line is the estimated expected deaths, and the based on prior mortality, and the red dotted line is the upper bound. It's essentially the upper confidence limit for that estimated excess deaths estimate. And then, of course, the solid blue line are observed deaths by week. I just wanted to point out here that, obviously we've had a lot of excess deaths over the last couple of years during the period of the pandemic, and while that has subsided in 2022, and we still had excess deaths going into 2023. Although starting at about week 5, which is sort of the end of January, early February, we see the excess deaths drop down into a more sort of what we would expect position. Now, these are provisional data, so the numbers could be a little bit bigger, but the timeliness of the data is such now that we don't expect that to change a whole lot. The question is, what will happen in the wintertime? Will we see a spike in excess deaths similar to what we saw last winter, driven by COVID and perhaps even by influenza, and RSV is also becoming an issue. Next slide. Here I have some cause-specific mortality, some shorter term trends than what Steve showed. But these go through the first half of 2023. So I was able to pull some provisional data from for 2022, which 2022 is nearly complete at this point. And of course, 2023 is still quite provisional, but I was able to pull from the first half of the year. You can see, very clearly the deceleration of improvement in heart disease, and a little harder to see with cerebrovascular diseases or stroke there, but you've seen some similar pattern with cardiovascular diseases more generally. since about 2010. We've been seeing that deceleration and improvement. And then, of course, during the pandemic, we saw a bit of a spike in cardiovascular disease mortality. Now, that does seem to be improving when we look at the 2022 and the 2023 data. There are questions, of course, as to what will happen going forward. With cancer, we actually didn't see much change in 2020, but in 2021 and 2022, we did see some increases, and this may be perhaps due to interruption of healthcare access during the pandemic. It's hard to know exactly exactly what the relationship of cancer is to the pandemic or to the virus. But there does seem to be something going on there. The cancer's been declining pretty much in a straight line. And of course, that was disrupted by the pandemic. I'll just briefly point out unintentional injuries that was mentioned by Steve. This is being driven by drug overdose mortality primarily. We only have data here through 2022 because of the nature of death investigations and the time it takes. We really don't have reliable 2023 data yet for that, nor do we have that for suicides or homicides. I'll just mention that as well. You can see the really big spike in diabetes mortality. That appears to be coming back down. That said, it's been pretty flat over the last decade. We'll have to see whether diabetes comes back down to the pre-pandemic levels or not. We're not quite sure. Chronic liver disease, this is being driven, primarily, I think, by alcohol abuse, and you can see the large increase during the pandemic there as well, although that seems to be turning down also. We did see in the initial, for suicides, we did see in 2020 a decline in suicide, but since then it has gone up. And we recently reported on suicides. The number of suicides for 2022 looks like it'll be the highest number ever, although the rate, I'll say, isn't the highest ever. There were higher rates in earlier years pre-World War II. And then the homicide rate also jumped up during the pandemic, and that it seems to be a downturn as well, although we'll have to see what we get when we see the 2023 data for homicides. Next slide. And then I'll just say something briefly here about drug overdoses. Drug overdoses, I think, are important because they really have sort of put some upward pressure on mortality rates over the years. Even when mortality was declining, wasn't declining as fast as it might otherwise because of the increases in drug overdose mortality. I have data here through March of 2023. These are annualized numbers, so each data point is sort of a 12 months ending for that month. You can see for the most recent data for 2022 and 2023, it seems fairly flat, which is, I think, good news. That said, we saw flat mortality in 2018 and most of 2019 as well. And we got a little excited about that, only to see it start to increase pre-pandemic, actually. That increase that you see there for 2020 and 2021 actually started in late 2019. And then we saw that fairly steep increase. So it'll be interesting to see what happens there going forward. That's all of the data I have to show, but I do have some thoughts on forecasting future mortality. And I think the upshot is that the pandemic's really sort of disrupted our projection modeling. It's been quite, I think, frustrating to those that do that sort of work. some of the questions I think that we have to ask as we're sort of trying to do this is, whether the virus, SARS-CoV-2 virus, will likely become endemic. I think it is becoming endemic, and we have to think about what that will look like going forward. We do have some new variants coming around. There's a new one, BA.2.86, which is I think it may be important going forward. And then, of course, we have to take into account the possibility of medical advances. We talked about drug overdose mortality and what will happen there. Obesity was mentioned also. Will the trends in cardiovascular disease mortality continue? Will we continue to see this sort of flat curve? And then, post-COVID conditions was mentioned by Steve. I think that's important. We've got, there was some recent research in Nature Medicine that was published a few days ago, and that suggests that there may be some longer-term effects that we may not have understood to this point. And then the interruption of healthcare access and chronic disease management, especially for things like cancer, hypertension, and diabetes, and how this will impact things. So since my time is up, I will wrap it there and turn it back to Emma.
Thank you, Bob. And I'll now turn it over to David Cutler for his presentation.
Thank you very much. I was going to say thank you for inviting me, but actually I hate you for inviting me. And the reason is that you always ask me questions to which I don't have the answers. And so I feel like I'm sort of always saying things and only hazarding guesses. So I'm going to say one thing with absolute certainty, and then I'll guess at a couple of others. So if I can jump to the next slide. The thing that I'll say with absolute certainty is that in expectation, most people will die, unfortunately. So that's a very strong statement that I want to leave you with. But what I want to do in the less certain end is do two things which are related to what Steve had asked us to think about. One is talk about COVID and mortality, and then second is to talk about general mortality trends. So let me start first with the COVID and mortality. And so if I can jump to the next slide, I'm going to be very, very brief in the pictures of this, but just to give you a sense, so you can see relative to projections, mortality went up obviously in the first year of COVID, and then it's sort of come back down since. And so one way to think about this is, in sort of normal COVID, we're heading back towards normal mortality, whether we make it or not, I don't know. And I'll give you a way that I think one might get at it in just a couple of slides. The question is, what is the end game? And this has come up a couple of times. So on the next slide, I've sort of tried to map out what I think are possible end games. And the one in bold is the one that I think is most likely here. Eradication is one, like smallpox. The difficulty with eradication is that the things you can eradicate are things without natural animal reservoirs. And COVID actually does have natural animal reservoirs, so we find it very difficult to eradicate those diseases. We can eliminate through vaccination and so on. It's harder because, as best we can tell, immunity wears off and the virus mutates more than do other viruses. So I think the two most likely scenarios, the sort of happier of the more likely scenarios, is cohabitation. So it becomes kind of like the seasonal flu. This is what I think is likely to happen. Although I will note, even in 2022, COVID deaths were 3 times pneumonia and influenza deaths. So it's still not down to the level of the seasonal flu, or periodic conflagration like Ebola, with possibly large and serious outbreaks associated with new variants. One of the things that we've learned is that our ability to develop vaccines is much quicker than what we had thought. So, the COVID vaccine was by orders of magnitude far more rapid than anything else. So I don't, my inclination is that something like 3 is the right model. And then the question is, what would 3 mean? And so, let's say you thought it's not going to be 3 times pneumonia and influenza deaths, but let's say you said it was just going to be, an expectation, the equivalent of pneumonia and influenza deaths. Then the real question becomes, how many of those are sort of new deaths and how many of those are just deaths that would have occurred for another reason? that for another cause, but that instead occur here. And Steve, of course, brought this up earlier. And so on the next slide, I actually give, I haven't done this, and I thought of trying to do this, but I didn't have enough time, which is one could sort of look at the impact of the seasonal flu on total mortality. So there are, years where the flu is better or worse. There are states where the flu is better or worse within years. So one could actually estimate something that says in a year where pneumonia and influenza deaths happen to be worse for some reason, either there's happen to be worse or if one has some instrument like, the vaccine is not quite as good in that year, or there's a particularly bad outbreak in a particular area of the country in that year. What is the impact on the total death rate? And I think I would, if you think the future of COVID is something like cohabitation, I would find something like this to be a very relevant thing to do. As I say, I haven't done it, but there's no reason why this couldn't be done. Maybe Bobby Anderson will say some reason why it can't be done. But this seems to be like at least one substantive thing one could do to try to learn about the impact of sort of of seasonal COVID, if you will, of a long-term living with COVID. So that's what I wanted to say about COVID. I know there are sort of other issues associated with long COVID and what long COVID will do to longer term mortality. We don't really have a great sense of that at all. My sense, by the way, is that just as a guess, long COVID seems to be less long lasting on average than, say, long SARS was or long MERS was. So if you look at like what share of people still had those diseases a few years later, it seems to be that fewer people have COVID symptoms a few years later. But that the science, that's sort of more impressionistic than it is scientific. Okay, so let me then jump in the next slide to non-COVID mortality trends. And there are any number of things going on here. There's really huge benefits in terms of mortality and heart disease treatments. There are deaths of despair, there's chronic maternal mortality, and so on. And these have not played out in the same way across the entire spectrum of people. So on the next slide, you can see a little bit about what that looks like. So this is the change from 1999 to 2015, which is the data I had close at hand, for 3 different race and ethnicities on the trend in mortality by age. And you can see that, you can sort of see the prime age higher deaths, particularly for non-Hispanic white males. And then you can see that's in a particular age group, that is prime age, say 20 to 59. If you look either younger than that, you see no differential trend for prime age white males, or importantly, if you look older than that, it looks like mortality rates in the elderly population and near elderly population were declining at roughly the same rate for all the different groups. Similarly, within the prime age male population, there are a lot of differences, and those differences are obviously very important because these are very big demographic groups. Just a couple of things to take from this. One is that there's a lot of different stuff going on. So there's not a single trend here. There's not a single thing that's going on in the data. And related to that, to the extent that it's socioeconomic, and I'll get into that in a little bit, and I suspect Steve and Steve Wolf will get into it some, as will Chris, is I think that increasingly, I am less and less happy with the idea of talking about the average mortality rate or the average life expectancy in the population, because what we've seen is a huge divergence between better off and less well off groups, and we may need to model them separately. And certainly when we think about policy, we'll have to think about them separately. But let me give you my sense about the various trends that I see going on, and they're on the next slide. And I've given you a couple of sites down at the bottom, but I'm happy to provide more references should people want. So there are at least 4 things that I think of, probably 5 things that in the different sort of rows, the 5th one being future pandemics, which we kind of find it very, very difficult to guess about. But 4 things that we can at least know about. One is medical progress, which is very, very difficult to know. And sort of we talk a lot about that. There's the sort of good stuff like the statins and the antihypertensives, and there's the bad stuff like the new opioids. There are things about how well we do with the system and so on. To my mind, what we've learned about is that the best stuff in terms of extending lifespan is actually low-cost prevention. So if you say, what has been the most effective in extending lifespan, it's that. So I would worry less about, do we develop a new drug to treat refractory cancer of X, and more about, do we develop a ADRD prevention medication or cancer prevention medication? And so that's sort of where I would go there. And of course, healthcare access and all sorts of other things factor into that. The second one, which is really very important and doesn't get discussed so much, is pollution. the decline in pollution has had a very big effect on both length and quality of life. Third is social insurance programs, and I put in there sort of the balance between how the economy is treating people and how society is treating people. Most obvious difference between the prime age population and the non-prime age population is that social insurance is much more generous for the non-prime age population than the prime age population. And so that's probably related to the trends on the previous slide. And then there are risk factor changes, and these were also brought up earlier, where there's been a huge reduction in smoking and an increase in obesity, sort of which way those will all work out. I don't know the answer to how those will work out. On the next slide, I've given you not my guess, but this is if when we're trying to define like conventional wisdom or something, this is from a sort of guess about what that might be. All this is just to say that there's a lot of stuff that could be on the horizon. But again, when I look at this, the thing that I want to draw my mind to based on the past is just the sort of prevention. That's where I want to think the most. So I'll just jump to the last slide and then I'll wind up there. Just keep going, please, through this and just go to the last slide. I was going to make a point, but keep going, please. One more slide, please. If I had to bet, I would bet that progress is more likely than regress because you only have to solve a problem once. But as Karen was saying, we want to think about a healthy lifespan, maybe a better bet than extensions in the oldest age. And then finally, I want to think about prevention and social structure and health as being kind of where I want to focus the bulk of my thoughts on this going forward. So let me stop there and thank you very much.
Thank you, David. Next, we'll have Chris Murray.
Thank you very much. If we could go to the next slide, please. So I'm going to give a perspective on forecasting life expectancy by state in the US. And I just want to say that it's a very data intensive approach, and it is built off a study that's now been running for 30 years called the Global Burden of Disease study that involves about 10,000 people around the world in accumulating all the epi-data that's out there on diseases and risk factors and cause-specific mortality. Next slide. And if you're interested, you can go to our website, healthdata.org, and you can play around and explore the results using online data visualizations. So I'm going to go from using the Global Burden of Disease project as a base to what might it mean for the future. Next slide. So we've been trying to forecast cause-specific mortality and, of course, all-cause mortality for a long time. The first attempt was in 1997, and that was for the globe and at the regional level. And then we've started up a forecasting program, and I'll explain more what it's based on, and started publishing in 2018, and we'll have subsequent papers, and there's a number coming later this year as well on forecasts. And these are for many locations in the world, and of relevance to this discussion, these are at the state level for the US. Next slide. So the key thing here is in the model that we've tried to build, we've tried to bridge the epidemiological world, where there's a lot of interest in the drivers, smoking, for example, that David spoke about, or obesity, or drug use, and the tradition in demographic forecasting of essentially using time trends in more or less sophisticated matters, where you say, we've observed a pattern in the past, and we're going to extrapolate that into the future. And there's pros and cons for both of these approaches. And we've tried to bring the two together. And one of the key things that's in our model is that we have many drivers, like smoking is now explicitly in the model for the future, but that does require us to make forecasts of those drivers. And those, of course, can be wrong. And so there's benefits for either approach. I don't want to argue that the explicit drivers is the only way to go. Next slide. Now, this is just a visual of how we relate the global burden of disease, descriptive analysis, for example, state by state in the US, what has been the changes up until present for obesity or smoking or air pollution or temperature, which is built into this modeling. And a long list, actually 82 different risk factors, as well as other socioeconomic drivers like education and income that factor into the sort of time trends. But on the left-hand side here is the GBD analysis, and then on the right-hand side is this forecasting platform. And because of the nature of all the factors that could be influencing the trends, from pandemics to drug use and alcohol use, et cetera, by its nature, what we've built is really quite complicated because there are many of these different drivers. And of course, the more complexity you have in the model, the more scope you have for getting it wrong. On the other hand, when we do measure forecast skill, we are able, with this much more detailed modeling approach, to match or in most cases exceed the more traditional demographic forecasting approach where you don't have these explicit drivers. Next slide. So there's three parts to our model. And the way we do this is we take the exposure data for all the risk factors. We take systematic reviews of the relative risk of mortality by age and sex for each of those risk factors, and we remove the effective risks from the past. So we have an underlying trend that's not explained by smoking and air pollution and obesity, et cetera. And then that underlying factor trend, we try to explain with socioeconomic variables. And then we have a third component, which is an autoregressive component that helps the model perform and capture things that are not in steps 1 or 2. Next slide. So here's just a visual of all the risks that go into our model. And in some cases, because they have a dominant effect, less in the US, we also have some interventions included in here. So vaccination is included, as is antiretrovirals for HIV. And as we get more and more data on the coverage of certain interventions, we can include those as in this list of drivers that go into the model. But I think in terms of the early discussion, we are trying to capture climate change. We are trying to capture obesity. We are trying to capture, the drivers of things like drug use, as well as all the other things listed here, like the 4 factors that David was referring to as promoting progress are implicitly here or explicitly here. Next slide. Now, I'd love to report on skill. We've adopted what the weather community does and now trying to report on forecast skill. That is how much better than a baseline model you are at forecasting, and where in this case, the baseline is just constant rates. And we have done that in the past. Our previous version of the model published in 2018, we did report on skill, but for the current version, which will be published later this year, I don't yet have the results to show you on skill. It's very interesting when you look at skill of people's forecasts. There's a lot of models that don't have any skill. And so it's sobering when you look at forecast skill, and that's true for economic forecasting, COVID modeling forecasting, which we're very heavily involved in, or in this case, demographic forecasting. Next slide. Okay, so here's the main result, bringing everything together. These are state-specific male and female trajectories of life expectancy. You can see the rise that was occurring and then the flattening out that Bob has spoken about, the big drop in life expectancy due to COVID. And then you can see our forecast, taking all these factors into account, has quite modest improvements. And in the case of females, around about mid-century, the sort of consequences of obesity, drug use, combine and suicide in some age groups to actually stop expansion of life expectancy. So and there's also a flattening, but not yet quite a decline for males expected as well. So our forecasts for the future, taking all these factors into account, are far less optimistic than what we would have said if we'd run these models up to 2010, before the sort of essentially the obesity wave caught up to cardiovascular disease in the US and has led to the flattening of cardiovascular disease. And in fact, in half the counties in the US, cardiovascular disease deaths are actually going up already. And not coincidentally, those counties are the ones where the obesity epidemic is farther along. So that's our take on what might be coming. Of course, if we were to show you the uncertainty intervals on these, they're appropriately very large. Thank you.
Thank you, Chris. And now I'll turn to Christopher Room.
Hi, thanks. Thanks for having me here. Very interesting panel discussion. If you go to the next slide, please. So I'm going to talk primarily about the whole notion of what are sometimes referred to as deaths of despair, and then I'll talk a little bit about heart disease and obesity. So you probably all heard this term deaths of despair. This was formulated by Case and Deaton. And what they are referring to primarily when they say deaths of despair, that's deaths due to drugs, suicides, and chronic liver disease. They actually mislabel that as alcohol. Alcohol deaths are much broader. And in what I will show you, I'm actually going to use a broader definition of alcohol deaths. They came up with this really initially as an explanation of rising mortality rates among midlife whites that we saw starting around the turn of the century. I'll note that despair is not defined, but that's a hard job. The question is this a useful concept? And my argument would be, at least at the current state of understanding, no, that it actually conceals more than it reveals. And that if we look at the components, we can make much more progress. Next slide, please. So this is showing you age-adjusted mortality rates for the three components of what are referred to as deaths of despair. Again, I'm using a broader definition of alcohol. A couple of things to note here is that the patterns are quite different. So the notion that they're caused by the same thing or that they have the same source isn't obviously true. We would also see this if we looked, say, at variation across states or across groups. We're going to see quite different patterns. And certainly if we look at the growth, drug deaths are the key. I mean, there have been growth in suicides and alcohol deaths. Some of the alcohol pieces was mentioned, maybe a COVID effect, but that's swamped by drug deaths. Next slide, please. So you can see here what I've done is normalize these. So 1999 is 100, and this shows this very dramatically. Drug deaths have gone up over 500%. The others much less. Next slide, please. So just a couple of points to mention in terms of this notion of deaths of despair. One thing you'd want to ask is, why weren't non-whites affected until very recently? So the notion of deaths of despair, as Case and Deaton proposed it was the cumulative effects of a set of things, economic and social factors, that have been going on since the 1970s. And in fact, they argued it was not a specific effect of specific economic downturns, but rather this broader set of things going on, really starting in the 1970s, if not before. And it is very difficult, at least for me, to see why those same factors would not have been affecting non-whites, or at least that the timing was very different. So non-whites actually saw a big increase in deaths during the 1990s, some of which was probably associated with the crack epidemic, but then not after that until very recently. And interestingly, what you don't hear about is that deaths of midlife whites were actually falling in the 1990s before this increase. And so those same social factors were going on. So why did, what was the timing? Next slide, please. So I'll come back to say a little bit more about despair, but and this you've already seen. I will note that a lot of the increase in life expectancy and reduction in mortality was due to declines in heart disease mortality, which has been discussed as flattened in recent years, particularly since around 2010. I think David had a lot more to say about that than I do, but that is clearly one of the key factors. Next slide, please. Now, I don't want to say that there isn't a potential role for despair, or maybe we should call that poor mental health. So this is showing you evidence from the behavior risk factor surveillance system on the number of days people were reporting being in poor mental health in the last 30. And so the green line here is showing you the number of days. And then the orange and blue lines, and these are, look at the right axis, are showing you the probability of having at least 15 days of poor mental health in the last 30 days, or of all 30 days. And you see that all of these are increasing over time. So something appears to be going on in terms of worse mental health. Next slide, please. So this is showing you the same information, slightly different in two ways. One, I've normalized this to, so 1993 here, the first year I look at, is equal to 100. And you can see, I mean, this is really quite rapid growth. It's actually particularly rapid at the kind of more severe, at the all 30 days, or the greater than 15 days. And the lighter dotted lines there are actually showing you adjustments. The original ones are just raw numbers. These try to adjust for things like age and population changes. It doesn't change the story. So the notion that something bad is going on with mental health, I think, is quite plausible. How that's related to mortality rates at this point is unclear. Next slide, please. So I want to conclude here by talking a little bit about the dangers of rising body weight. And so here what I'm showing you are, this is data, NHANES data, starting in 1999. So these are 2-year intervals. So like 2000 is 99, 2000 going to 2018. We don't have great data during COVID, and the most recent 21-22 data have not been released yet. But the first thing you notice here, and this is not a surprise, is that all of these, all of the measures of body weight are increasing over time. That is well known. You'll also notice, though, and this is hard to see in this slide, I've actually done more divisions than we normally see. 25 is overweight, 30 is greater than 30 is obese, 35 is class 2, and 40 is class 3 obesity. I'm actually showing you 45 and 50. So these are, really severe overweight. Next slide, please. This is showing you how all of these, again, normalizing to 99, 2000 is equal to 100. And what you see here is the fastest increase by far is in the most severe measures of obesity. And one of the things that I think has not received enough attention is when we look at, certainly if we look at being overweight, the mortality risks seem fairly small. Even if we look at what is obese, so if you look at somebody who, say, has a BMI a little above 30, my reading of the literature is there are probably not major mortality effects of that, although it may well be the issue that was raised earlier, if that's sustained over a lifetime, that could be an issue to worry about. But certainly when we get to these extremely severe measures of obesity, that has incredible health risks, and they're increasing very rapidly. I think one of the questions going forward that, kind of in this group we need to struggle with is we have not had effective treatments for these in the past. That is, if you look at changes, if you look just projected trends out in a sophisticated way, not a lot of deviation from those. We do have some new treatments, specifically some of the new medications that may actually kind of bend this curve, and that's going to be really important to see. All right, thank you very much. I'll stop there.
Thanks, Chris. And last but not least, Steve Wolf.
Thank you. Good morning, and a pleasure to join this esteemed panel. I'll try to be quick so we have more time for Q&A. If you could go to the next slide, please. So this is a slide showing U.S. life expectancy relative to 16 other high-income countries. The red line is the United States. The dark black line is the mean life expectancy across those 16 high-income countries. And this is plotted through 2021. So there's several things to point out here. Obviously, you can see the effects of COVID-19, during which the United States experienced a devastating drop in life expectancy. Other countries also took a hard hit, but you can tell that the United States loss was considerably greater. But what I wanted to emphasize more is the long-term trend here. You can clearly see a dramatic problem in the United States in terms of its performance in life expectancy at birth compared to other high-income countries. So a lot of the data you've seen already is focused on age-adjusted all-cause mortality rates, and we could go through the similar exercise with that. But the point to be made here, and my main thesis, is that unless we address the root causes of this, I don't think we're going to see promising progress with either life expectancy or mortality or longevity trends going forward. Next slide, please. Several comments have been made about the decade preceding the COVID-19 pandemic. This is another variation on the same thing. We saw something happen around 2010 where all-cause mortality rates in the United States began to stabilize or flatten. And as I'll talk about in a minute, increase in certain age groups. Headline news from 2014 to 2017 was that the US experienced 3 continuous years of decreasing life expectancy. There was a problem already underway before the pandemic came along. And so when we talk about whether we're going to get back to pre-pandemic conditions, it's important to contextualize that if we end up back at pre-pandemic conditions, we're still in a pretty bad place in terms of the standing of the United States. Next slide, please. I want to focus some attention, which I think David Cutler had a slide that began to speak to this, about what's happened to the young and middle-aged adults of this country. That a lot of this trend that we've seen in the mortality rates in the years leading up to the pandemic was driven by an increase in mortality among young and middle-aged adults, 25 to 64 years. This was the subject of a 2021 report by the National Academy of Science, Engineering, and Medicine, which looked in detail at the reasons for this. Christopher Room mentioned that the mortality rates were decreasing like we want them to in the years preceding this, and then the all-cause mortality rate began increasing. The cause-specific mortality rates responsible for this trend began increasing much earlier. The NASM report that I mentioned identified 4 major causes for this increase in midlife mortality. Drug overdoses was obviously the leading one. Secondly, suicides, alcohol abuse, and cardiometabolic diseases, which was a term that the committee used to refer not only to trends with heart disease, but also with obesogenic diseases like obesity and diabetes. And so you're hearing a theme in these presentations that this trend with obesity and heart disease is a major player in trying to understand what's going on, certainly with the pre-pandemic trends that we're showing here, but also in trying to forecast what's coming down the pike. I want to endorse Dr. Room's point that we should stop using the term deaths of despair. It's very problematic. I do agree that despair is a problem in this country, but it's not a clinical term. There's a lot of proximal causes for those deaths that have little to do with despair. And that it's much healthier for us to talk about what are the specific causes of death that we're referring to, and then to dig deep into the root causes for those, rather than quickly labeling them around that particular name. Next slide, please. I also want to take a moment to draw attention to the pediatric population. In David Cutler's slide where he showed the increase in mortality in the midlife age groups, you saw that the younger age groups and the older age groups were heading in the right direction. That was the sort of bright spot in the years preceding the pandemic. Obviously, during the pandemic, mortality rates in older adults increased dramatically for obvious reasons. What's worrying, though, is that the age-specific mortality in the pediatric population is now increasing. In the NCHS report that came out last December, reporting final mortality data and life expectancy data for 2021, the report noted that every age group above age 1 experienced an increase in all-cause mortality. This slide is showing you all-cause mortality for ages 1 to 19. It's showing a dramatic increase during the COVID-19 pandemic, but it was actually driven by factors that began many years earlier. And the significance of this is, just to put it in plain English, if all-cause mortality is increasing at ages 1 to 19, that means the probability that our children will reach age 20 is now decreasing. So I think our thinking about longevity and life expectancy trends has to give some serious consideration to what's happening in the younger population of this country. This trend that you see on here was also driven by 4 major causes. One was suicide, which began increasing in 2007 in the pediatric population. So this is a longstanding trend. Second is homicide, which began increasing in 2013, with most of those homicides involving an adult killing the child. The third, drug overdoses, which began increasing before the COVID-19 pandemic, about 2019. And then finally, transport-related accidents, which began increasing during the pandemic. Whether that particular cause of death will continue to be an issue in this age group remains unclear, but the persistence of the other causes of death prior to the COVID-19 pandemic raises serious questions as to whether we'll be continuing to deal with this problem going forward, even when COVID-19 ceases to be our major concern. So I'll stop there and look forward to the Q&A.
Thank you, Steve. And thanks to all our panelists for your presentations. A lot to think about and many places we could take this conversation. Steve and Karen, I want to start by giving you an opportunity to react to anything we've just heard or pose any initial follow-up questions to our panelists or the group. And then we'll go to board members after that.
Well, thanks, Emma, and all the people that you've invited on the panel and their wonderful presentations here. Let me just start first, and then Karen, I'm sure we'll have much more to add. This was really a wonderful presentation here, because what we have always thought about, and this speaks a little bit to Chris Murray's concept of skill and forecasting, what we have always struggled with is it's great to gain a great understanding of what's happened in the past and the conditions of the past that have contributed to the data and the trends that we've seen in the past. But the real challenge is to imagine, to try to foresee, how will those conditions be in the future? Will the conditions be exactly in the past? If so, great, let's get out a ruler and develop our projection over past trends. But if we see conditions being different in the future, then that is really major. And all the panelists here have shed tremendous light on that. I think that the great questions we have really are, obesity. I think several, I think everybody has really addressed that in this rising body weight mass, obesity in the future. And in the prior century, we were struggling with having adequate nutrition for everybody. And now we sort of, we still had that to some degree in some of our population, but now we're over nutritioning perhaps. And that's a real serious issue for the future. I guess the question really to the panelists is, do we see this continuing, or do we think we're public health, announcements? Are we going to continue to have too much candy, too much things that are make us obese, and that's going to continue to have issues in the future? It looks like Chris Murray's University of Washington projections are assuming that there will be some of that. The other, of course, is the drug abuse, and our sense of the drug abuse early on, a lot of it was over-prescribing. But since then, it's gotten to be much more than that. And I'm wondering, what the panelists are thinking in terms of things like fentanyl and similar that are not prescribed drugs that then become available in the population? Is this going to continue to be a problem as it is, get better, or get worse? So this really is the gigantic question, is not just to have a model, as Chris Hernandez has mentioned, but what are your inputs? What do you assume will be happening in terms of your dependent variables in terms of pushing us into the future?
Steve, does any one of our panelists want to respond to Steve on any of those points?
I'll just jump in on one on the drug overdose part. Historically, most drug overdose epidemics have been self-limiting because people don't really want to die, and policy comes in, cuts back on the substance, people decide not to take it, and so on. So my thought sort of for a while was that like many things, drug overdoses would be self-limiting. Obviously, 30 years is a long time to not be self-limiting, but we shouldn't forget that there are factors that will work in the other direction, like people will get used to what's going on and decide they want to avoid those situations. So it over my long-term projections, I don't like have it go out, continue on, because that just seems absurdly different from past epidemic experiences.
So,
but even David, even if it doesn't continue rising, will it stay at about the same level, or will we drop back? It looks like Chris Room has an answer, hopefully.
well, I don't know. I don't have an answer. I have some thoughts and also a thought on obesity. So, clearly, yeah, what started, or a major driver of this, was overprescribing. That is not the major driver now, although certainly some of the, things that came from that can be what we're seeing. I agree with David in the sense that I don't think the trends can continue, the rapid rise. I just don't see how that can continue. What is less clear to me is, the levels, and can there still be some rise? I mean, fentanyl has turned out to be just this, horribly dangerous drug. And so far, I don't see that we've gotten a handle on it. But so I don't know, whether we have some modest growth, we stay where we are. I mean, we'd like to think it's going to fall, but I haven't seen evidence. I want to say on obesity, so I actually did some projecting about 20 years ago of both obesity rates and severe obesity rates, and recently looked at how that did. And it was a fairly flexible projection exercise, and it did really well. And the bad news there, I mean, really well at predicting. And the bad news there is that suggests if things continue as they were, these kinds of projections, I'm actually in process of pushing them out into the future, but it suggests rapid increases in obesity, and particularly in severe obesity. What I do think, the thing to watch is we do, for the first time, seem to have some treatments that are maybe effective. And is that going to change this, and how? And so I would say over the next 2 or 3 years, looking at what happens to kind of really severe obesity when we have these new drugs, is that changing the trends? That's going to be really interesting to look at, but it's too soon to tell as far as I know.
Steve Wolf, you have your hand raised, and then I see Nancy's unmuted, so I didn't know if she had a question after that.
Sure. I wanted to respond to the question, also talking a bit about the trends with heart disease, but coming back to obesity. A lot of the data that we've shown in the panelist presentations is looking in aggregate at heart disease. But when we start decomposing heart disease mortality by cause, we start learning some things as to what's responsible for the flattening of that curve. And one of the clues to what might be going on is that there are certain forms of heart disease mortality. I'll use hypertensive heart disease as an example, where we've seen an increase in mortality. There's a number of different causes of heart disease that probably have obesogenic origins that may be responsible for those increases, but finding out why those forms of heart disease are claiming more lives, I think, is going to be important. I really, as a social epidemiologist, my training is to look upstream to try to understand the factors responsible for these conditions. It's as if we have an airplane that's had an explosion in its fuel tank, and we're trying to predict how likely it is for the plane to complete its flight without having any discussion about the fuel tank. So when we think about obesity and its persistence, despite any number of diets and drugs being thrown at it, we need to go upstream to think about what are the drivers responsible for that. So anecdotally, the fact that obesity rates are higher in lower income individuals and households, if you are a family that's trying to make ends meet, going from paycheck to paycheck, and healthy foods of the sort that doctors would recommend are extremely expensive and outside your budget, but there's a density of fast food outlets where you live, and for $3 or $4 at McDonald's, you can feed the family. That's what you're going to do. We have a food industry that has made high calorie dense foods relatively inexpensive. So that has resulted in excessive caloric intake in the low income population. Dealing with the economic circumstances that are driving people to those choices is part of the solution. It's part of looking at the ruptured fuel tank. I'm not optimistic that these trends are going to reverse themselves unless we start dealing with those root causes.
Thanks, Steve. And Nancy, I see you're on camera and off mute, so I'll recognize you first and then I'll go to other board members.
Thanks. So I was actually just jumping in, waiting for the board portion because I've got lots of questions. This has been so very, very informative. As I say, I've got lots of questions, but let me start with one so that I don't monopolize and give the other board members a chance. You've been talking about general trends and these various causes, and I'm thinking about if you could talk a little bit more about disaggregating them. David did talk a bit about trends of people of color, low income. You know, I think the conventional understanding is that that while there's been a slower increase, there's actually been stagnation or even a decline in some parts of the population and more rapid rises in others. And of course, some of these factors, when you talk about cancer, that affects everyone across the board, but some of the, the drugs, other of those factors might hit certain populations more than others. So it's just sort of an open-ended question for everyone to just, for a few minutes, to talk about the differential mortality effects.
So I can jump in on a couple of things. So when we look at suicides, those have primarily been a white phenomenon. Not, I think maybe not entirely, but mostly. When we look at drug deaths, so, if we were looking in 2010, 2013, let's say 2010, or a little later, we would have said that this was mainly occurring among non-Hispanic whites. And, a lot of the reason we think was that they were more likely to be prescribed opioids, which turned out to be quite dangerous. But if we look more recently, we have seen rapid increases among non-whites, and this is partly related again as we've moved to wider distribution of heroin and particularly fentanyl. Those are affecting a much broader cross-section of the population.
Thanks, Chris. And I think Chris Murray also wanted to say something.
Yeah, we have a long-running, and now another 5 years, project with the National Institute for Minority Health and Disparities at NIH to look at not just cause of death, but also disability at the county, race, ethnicity level. And so we've started to publish from that. And, just not to complicate your task, but the patterns are very different by locality in the US and by race, ethnicity. So, there's good chunks of the US where the increase in drugs is still there, but it's quite modest. And then there are very focal places where the increase in drugs are in the thousands of percent if you go over the last 20 years. Likewise, we're seeing very different trends at that level by race, ethnicity, on cardiovascular disease, and I agree on you have to look at the specific causes. So lots and lots of detail there, and we just published an analysis of large groups of causes, and in fact, the disparities for some causes are getting larger, and for other causes they're actually getting smaller. So it's really the devil's in the detail there.
And does that correlate also with with income levels as well, or is that
income's so much harder to nail at the individual level. You have to go to other data sources that are not as rich or cover as many age groups. So we can figure that out by income level at the community level. And take, for example, obesity, where there's this sort of at the global level, there's an inverted U relationship. Very low income, where they can't afford food or not very obese. You have the highest level of obesity at sort of the next tier of income, and then it tends to go down. But that entire curve in the US and globally has been in every income group going up. So there are these disparities in the background, and then there are these trends on top that seem to affect many groups at the same time.
Thanks, Chris. And David, did you want to say a few words before we go to Amy for her question?
Yeah, I just want to, I don't know if this is feasible at all, but I think having the Social Security actuaries explicitly identify life expectancy by some measure of socioeconomic status. I agree with Chris that probably education would be my preferred over income, would be actually quite valuable, particularly as, given the need to think about Social Security reforms coming up, because one size fits all is increasingly not working.
Thank you.
Amy?
Thank you all for a really thoughtful presentation. You've given us a lot to think about, and I'm excited to see how the Office of the Actuary takes this information. We had some thoughtful questions in the chat that were also on my mind from Noah Meyerson and Hillary Waldron around the classification of death for COVID and whether or not there's any grayness in those classifications, whether perhaps someone who's classified as a diabetic death was actually a COVID death or had heart disease and then classified as COVID. So would be interested in hearing what you all are seeing in terms of research around the noise in the labeling of the COVID death data.
Bob Anderson, please go ahead.
Yeah, I can address that briefly. I mean, particularly early in the pandemic, we know that there was some misclassification, a lot of COVID deaths that were missed. And in particular, we saw a pretty big spike in the first few months for pneumonia deaths. And those were almost certainly pneumonia. It was pneumonia caused by COVID. And we think that that some heart disease deaths and some diabetes deaths in particular were also probably COVID deaths in that early period. Later, I think, as cause of death certifiers became more familiar with the disease and better at diagnosing it, I think that this is less of an issue. There probably still are some misclassified deaths, some deaths that were missing, but I don't think it's a huge issue in the later part of the pandemic.
Chris Murray, are you trying to weigh in?
Yeah, I generally agree with Bob, but I think because we've done a lot of analyses of COVID mortality, and again, looking across many countries, not just the US. And there was, as Bob said, there was undercounting early on, but certainly after Omicron, there's some reasonable evidence there's overcounting, over assignment to COVID on death certificates. And again, we see that in a number of places in Europe. We see that in some states in the US, and we can debate about the validity of that. But for example, we're not convinced that the increase in diabetes is strictly diabetes. It could be some misclassification of COVID, but likewise, there are, the number of deaths reported during Omicron, because everyone was being tested when they came to hospital, they died, and it can easily end up on the death certificate. So I think it's quite tricky in 2022 to make sense of things.
Yeah, I think that's generally true. In many instances, what we do see in 2022 and into 2023 is COVID being more often added to part 2 of the cause of death section. And generally for surveillance purposes, we just look for any mention of COVID on the death certificate, but it certainly can be parsed out. You can look at whether COVID was the underlying cause or not. I don't think that that the underlying cause numbers are overreported, but the multiple cause numbers may be to some extent.
Bob, June Deb, did you have any questions for the panelists?
Thank you, and thank you very much. This is an extremely interesting conversation. I wanted to go back to behavioral health issues, particularly suicide, mental health, substance use. Is there any data that you're aware of that looks at different states or different localities that have different levels of access to substance use treatment or mental health treatment? I'm speaking from someone in Oregon who's advocated for increased access to those services over the years, and we haven't done very well. So I'm wondering if there is any data to support the improvement of mortality when there's greater access to those services.
I think there is some data suggesting that better access does lead to improvements. And I'm blanking. There are a couple studies I'm thinking about, but so I do think there is some evidence of that. How strong the effect is, I'm less clear.
Mm-hmm.
And we certainly know that, again, I'm thinking about drug treatment here. We know that the really gold standard treatment is still not nearly as available as we think it should be.
I'll just throw in that again, in Oregon, we've embarked upon a bold experiment legalizing possession of serious drugs, and there's a public debate about the effects of that. And so, of course, I'm interested in any data or support for the efficacy of treatment. So thanks.
Steve Wolf, did you want to jump in?
I was just going to say that with these issues, it's really important to take a holistic perspective. I think mental health access to mental health services is obviously a huge issue. And I do also think that there is data showing the relationship between that and suicide rates. But we also have to think about, geographically, when we disaggregate the data, where these rates are highest. There is a suicide belt in the Mountain West. We need to think about access to firearms. And it's all part of a mix. The individual who becomes desperate and who might otherwise in the past have taken an overdose of pills that could potentially be reversed if they're rushed to the emergency room and so forth, or receive Narcan, has a gun in the closet, we're going to see a different outcome. So looking at the prevalence of firearm ownership and access, the increasing lethality of the firearms, along with issues like access to mental health services, as part of the holistic understanding of what's changing these rates.
Thanks, Steve. And Jagadish, I want to give you an opportunity if you had any questions for the panel.
Thank you, Amy, or rather Emma, sorry. So my question is more about the composition of the population both in the past and going forward. Obviously, mortality incidents and risk exposures by cause of death occur differentially for different types of people. And this has been alluded to in the previous discussion, but I just wanted to put a little more flesh on the bones here. And we know demographic projections suggest that the demographic composition of the population will change rather substantially in the future. Along dimensions, of course, age and gender is, usually taken care of, but also by education, race and ethnicity, marital status, family formation, dissolution, family size, income and wealth, and so on. So my question is just twofold, well, actually threefold. To what extent are past increases in mortality by certain causes traceable to increases in the shares of the population that are susceptible to particular causes of death? And to what extent does current research take a granular view, that is, by person type along these dimensions, for estimating future mortality? And the third part is, to what extent can we extend these projections out into the future? I mean, the actuaries and trustees are expected to make projections over 75 years at least. How far can these assumptions be? Ultimately, some trend rate projected for a few years has to be continued. What is the visibility into the future for these assumptions that we make? Those are my three questions. Thank you.
David, go ahead.
So I don't know if this is entirely responsive, but having just urged you to do some disaggregation, I'm leery about disaggregating too much. And the reason is, let's say you have, 10 causes of death and one of them is declining at a point in time, for the past 10 years, and then you forecast, you'll drive that one down to 0 and everything else will stay the same, and you'll conclude there's a limit on life expectancy. And of course, what that misses is that the other things change, that it's not set in stone at the smallest level that things will always stay the same. So cancer mortality wasn't declining until it was, and things like that. So I think I in general am not a fan of super levels of disaggregation, except where the data are so clear that it's really different models, by socioeconomic status in my mind. But I don't know what others think about that. I may be in the minority on that.
Steve? Goss. You're on mute.
Thank you, Emma. Yeah, if other of our guest panelists here will have opinions on these things, that'd be great. I just wanted to toss in a couple quick things to David Cutler's excellent points about disaggregation. David, I think you are aware, and I hope everybody else is, that Karen Gutt and others in our office have put together some really important material about not just the differential level of mortality, but also trends in the differential level of mortality by lifetime earnings levels, which of course is critical to Social Security benefit levels and our projections. So we have that out, and I believe we're not too far from having an update on that with additional stuff. Another little comment about what Bob Anderson was talking about. As Bob well knows, we in our office have been paying very careful attention to excess mortality overall, but also what we refer to lovingly as PIC, pneumonia, influenza, and COVID. And early on in the pandemic, what Bob and CDC were putting out was PI, pneumonia, influenza, and then COVID got added to it. So looking at those as a group, we think has sort of helped us a little bit in understanding, sort of the implications of perhaps misreporting. I'd just say that, Steve Wolf's observations of pediatric deaths recently is a little bit disheartening, and Chris Room's points about general health is also a little bit troubling. Just two quick questions about sort of expectations for the future, because Chris Murray specifically talking about his model showing with some continuing rise, but then a downward move towards 2100 on life expectancy is of course any projection in the future is dependent not just on the model, but what you are assuming. So if Chris could talk a little bit about what he's assuming about the trends in the independent variables that are driving that, and sort of in the same realm. David Cutler mentioned some of the advances we've had in inoculations, like in this pandemic, the mRNA, which I believe initially was thought to perhaps be something that would be used for cancer. Of course, it leapt to the fore in COVID-19. And should we expect that we're going to have some real positive effects, to not everything negative here, positive effects from mRNA or similar in the future?
Emma, can I jump in for 1 minute and just extend the question to Chris Murray? Chris, I know you also mentioned the effects of climate change. So if you could speak a little bit more about like the way you're thinking about that, I think that would work well in conjunction with Steve's question. Thanks.
Sure, thanks. So let me do climate first, and then explain the sort of what's in driving the slowdown. So for climate, what we've done is we've looked in all the places where we can find cause-specific mortality data by day and locality. And then we construct risk curves by temperature, by daily temperature. And we then have, like everybody in that field, noticed that those risk curves move around depending on, do you live in a cold place, a medium place, or a warm place, right? So we have these risk curves. They're all U-shaped, except for drowning, which is just a straight line up. You know, it turns out that people don't drown very much when it's really cold because they don't go in the water. But bar that, there are all these U-shaped curves. And then what we take is what is called CMIP6, which is the IPCC modeling consortium for temperature, and take the ensemble of all their models. It's about 20 models, depending on the scenario. And the one that's built into our forecast currently is called RCP 4.5, which is one of the temperature trajectories for the Earth. It's the one that most of the economists and policy analysts think is most likely to occur. We also can have a scenario where what would happen if there was much more aggressive, climate mitigation, and you can trace that out. In the US, temperature effects are really quite modest because there's benefits of reduced cold as well as harm from increased heat. And in some parts of the US, actually, the reduction in cold is a benefit that's larger than the harm from increased heat. In southern states, that's not true. Maybe the bigger effect related to climate that's in the models is PM 2.5, the air pollution part. And the difference between the two scenarios, what's called RCP 4.5, what we think will happen, and RCP 1.9, which is sort of the Paris Accords, is actually quite considerable for air pollution. And there's quite a lot of benefit to the US in terms of air pollution reduction and deaths related to air pollution. So how do we end up with that sort of, flattening and decline in our life expectancy? It's really the balance, Steve, of, the big drivers here, things like, will tobacco keep going down, which we model, yes, slowly, but yes. What happens to obesity? It'll keep going up because so far we've seen nowhere in the world that's actually reduced, anywhere in the world that's actually reduced obesity. And then, but you can construct a very different scenario just by moving those drivers one way or another, because you've got positive and negative things that can tip you one way or the other. I think the key insight is we have some real momentum in some of the negative things like obesity and drug use that we didn't have in the period from 1965 to more recently, up to 2010. And so we have seen the balance shift towards those negative factors. But of course, technology innovation could come along and completely change that story. Like, we've seen what the GLP-1s are already doing, but if you had mass GLP-1 use, as several people have commented, maybe that'll put a meaningful dent into obesity.
Thank you, Chris. Karen, did you have any other question before we wrap?
That was it, Emma. Thank you.
Okay. Thank you so much. So we are at time for this session. Thank you so much to our panelists and everyone else participating for an engaging discussion on this important topic. I now have the pleasure of turning it over to my colleague Conway Reinders to kick off the next session on the future of disability.
Yes. Thank you, Emma. I really appreciate it. So I'll ask the panelists to join me on screen for panel 2. My name is Conway Reinders. I'm a lead policy analyst on the board staff, and I'm pleased to be the session's moderator. So this session on disability aims to hear expert perspectives, discuss the implications of current knowledge to inform future trust fund assumptions. So let me just briefly reiterate the disclaimer that the information presented here is to inform the board and the public. The views expressed do not necessarily reflect the views of the board or a new board member. Again, in terms of logistics, we are recording the panel. It will be posted afterwards. Questions and comments are welcomed and can be submitted via the Q&A function, or can be emailed to events@ssab.gov. So this panel occurs at a time where disability incidence rates, the proportion of insured workers who file and are awarded benefits in a given year, based on SSA's definition of disability, has fallen steeply since 2010 to levels well below expected. So this panel will explore factors impacting technological and medical advances and changing workplace flexibilities. The Office of the Chief Actuary projects the number of people expected to receive disability benefits using 3 key disability assumptions: incidence rates, as well as death and recovery rates. So let me briefly introduce the panelists, and the full bios are available on the website. So in alphabetical order, Steve Goss has been Social Security's chief actuary since 2001. Steve has worked in areas of related to health and long-term care insurance, as well as pension, disability, and survivor protection. Alan Heineman is a psychologist by training, and his research centers on health services, chronic illness, and the psychosocial aspects of disability, focusing on developing and applying outcome measures in rehabilitation care. Alan is the director of the Center for Rehabilitation Outcomes Research at the Shirley Ryan Ability Lab in Chicago, and is a professor at Northwestern University's Feinberg School of Medicine. Chris Murray, in the previous presentation, is joining us as well in this session, and he's a physician and health economist who quantifies the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geography over time. This has implications not only for mortality, but for the disability panel. David Shaywitz is a physician scientist by training and has focused his career on biomedical innovation, particularly the opportunities and challenges in implementing emerging technologies. David is here in his personal capacity. Finally, Mike Stevens is the acting deputy chief actuary for short-range actuarial estimates at FSA. He leads the office's work on developing 10-year projections of the actuarial status of the trust funds for Social Security programs, among other work. So I'd like to thank them all for joining and participating in today's session. Like the last panel, we will start with a presentation by the actuaries. After that, Alan, Christopher, and then David will give their opening presentations. Steve and Mike will have a chance to respond, and then I will moderate a discussion by fielding questions from board members and posing other ones. But before I turn it over, I want to provide a level set on what we mean by disability in SSA's context. There are different definitions of disability. So Social Security's primary definition for disability for adults in most cases is this. The Social Security Act defines disability as the inability to do any substantial gainful activity because of a medically determinable physical or mental impairment that can be expected to result in death, or which has lasted or can be expected to last a continuous period of no less than 12 months. To meet the definition, the claimant must have a severe impairment or combination of impairments that make them unable to do their past relevant work or any other substantial gainful activity that exists in the national economy. So when we're talking about disability incidence rates, we're talking about the proportion of people who meet and SSA's statutory disability. So I just wanted to put that out there before we get started. And so let me just turn it over to Steve and Mike. Thanks.
Thank you very much, Conway. Let me just start with a couple words, and Mike and I will sort of go back and forth like Karen and I did earlier. And if you could just jump to the next slide. And by the way, Conway's point is really important. Our definition of disability really requires a severe impairment resulting in you're basically unable to engage in any really substantial gainful activity, work in the economy. And this pertains a little bit also to what a lot of people thought about impairments that might be related to COVID and post-COVID. You really do need to cross the threshold of inability to work to qualify under our plan. On this first slide, just very quickly, and Mike will discuss a lot more on this because Mike has been our go-to person in our office for really analyzing and developing the data on applications, which you see here. These are just people who have applied to our field offices. Applied to our disability determination services in SSA over the past year, starting 2003. And you can see we've been in the vicinity of about 1.5 million applications for quite a while. The so-called Great Recession 2007 and 9, not surprisingly, with a lot of people out of work, resulted in a burst in that. We expected that would come down and perhaps be down a little bit below the levels that we had prior to that recession, and then to sort of stabilize. But obviously, you can see the trend has passed through the levels that we had in 2003 to 9, and has continued on down to extraordinarily low levels that have persisted even into 2022 as we've been moving towards getting beyond the pandemic. You can see here how we have been working with our trustees projecting a rather rapid and immediate resurgence back to higher application levels for trustees reports, all the way starting with the 2014, 15, and 16 reports, which have not been realized. So our real question before us is, where are we going with disability application incidence rates and prevalence in the economy in our entire society? So Mike, let me pass the baton to you on this particular slide and take this and shed much more light for all of our sakes.
Okay, thank you, Steve. So as Steve mentioned, this is just a graph that's showing historical and projected numbers of disability applications, specifically for Social Security disabled worker benefits that are going to our DDSs, which is where the determination is made as to whether they meet the definition of disability that Conway and Steve mentioned. Just to sort of discuss some of the lines here, the actual historical experience is that solid dark black line that you see going from 2003 to December 2022. Like Steve said, there were about 1.5 million applications per year. There's some fluctuations there from about 2003 to 2007 or so. And then with the recession that started in late 2007, then we see the application volume starting to increase rather dramatically until it hit a peak of about 1.9 million in 2010. And this is sort of a typical pattern that we see in economic cycles where disability applications generally tend to increase during recessionary periods. The interesting thing is that we did not see that pattern during the very short-lived recession in 2020. But from that peak in 2010, as the economy was recovering, then disability applications started to fall, which, as you can see from the different projections from the various different trustees reports that we have there, which are the colored lines that Steve mentioned, is that we were expecting some decline from that peak in 2010. But historical experience has continued to decline rather dramatically all the way to just slightly over 1.2 million applications in calendar year 2022. So let's go on to the next slide here. So this slide looks pretty similar. So this is a graph that actually shows our incidence rates instead of numbers of applications. So this is showing our incidence rates for the DI disabled workers. And the incidence rate, I think like we talked about a little bit already, is that this is the share of our disability insured population that's newly awarded a disabled worker benefit in the year. Here we show these rates on what we call an age sex adjusted basis. And this just helps standardize the rates to help control for changes in the underlying age and sex distribution of the insured population over time. But the overall pattern that we see here is pretty similar to what we saw for disability applications. Incidence rates were sort of between 5 and 5.5 per 1,000 exposed from about 2002 through 2007 or 8. And then really started to rise sharply through 2010, which is consistent with the sharp rise that we had in the applications that we looked at on the prior slide. And since reaching that peak in 2010, just like the applications, there's really been a sustained and prolonged decline in this age sex adjusted incidence rate. The age sex adjusted incidence rate actually fell below 3.0 people entitled to awarded a benefit per 1,000 exposed in 2022, which is by far the lowest that we have on this graph in the 33 years of experience that we have here. Just also like the graph that we had on applications, in the various trustees reports, we've actually been assuming a fairly significant bounce back in incidence rates that just have not yet materialized. But you can see from the trustees reports projections that we're showing on here is that gradually the trustees have been slowly recognizing the prolonged decline in these incidence rates, and then they've been making some stepwise reductions in the assumed ultimate age sex adjusted incidence rate that actually goes into the projections for the trustees report. The decline in incidence rate, as you can see from the prior slide, is largely driven by declines in disability applications. And Steve is going to get into in a little bit some thinking that we have as to why applications have been declining. But just sort of looking at applications, we've looked at disability application experience in a lot of different ways by factors such as age, sex, geographic area of residence, including urban versus rural indicators. And we've also looked at it by what impairment are applicants alleging, what's their educational level. And while the experience isn't exactly the same across all of those demographic dimensions, it is remarkably similar. And the last thing that I'll mention here on both of these slides is that even though the supplemental security income that most of you are probably, the SSI program that a lot of you are probably familiar with, that certainly serves as a somewhat different segment of the American population, although there's some overlap with DI. The experience for SSI has been very similar to DI disability as well, especially noteworthy that SSI children also have very similar experience, and they actually have a very different definition of disability than adults do, as many of us know. So with that, I will turn it back to Steve, and he will discuss the implications of this on beneficiaries and prevalence.
Thanks, Mike. And staying on this one slide just for the moment, I mean, really, as Mike described, what's really notable here is that our disability incidence rate, well after we got past the so-called Great Recession of 2007 and 9, all the way through 2019, continued down considerably below the incidence rates that we were having on average in prior periods. We got down to about 4 per thousand. Quite a bit below the 5 per thousand. Now, in our long-term assumptions, we have pulled down, as Mike indicated, our ultimate incidence rate assumption to about 4.8. But the gigantic question before us is, have conditions changed in the population, nature of work, which will be an next panel later on, and in other aspects that suggest that we should be having a lower ultimate incidence rate than even the 4.8 that we have gradually come down to. Now, the implications of even being at that 4.8, if we go to the next slide, we can see, as Mike was indicating, what the implications are for our disability prevalence rate. This is an age sex adjusted look at what percentage of our population at ages that they could be receiving disability benefits under the Social Security Disability Insurance Program will actually be in payment. And you can see that what we've got here on the solid red line on an age sex adjusted basis relative to the solid black line, which is also age sex adjusted on the historical period, that we're basically projecting that we're going to be rising back up by having that 4.8% incidence rate, going back to that relative to what has been much lower than that ever since about 2013, rising back up to prevalence rates that are at about the level we were perhaps before the Great Recession. And the question is, should we be expecting that we will have a prevalence of disability as per our definition, as Conway mentioned, rising back to that level? Is that about right? Might it go higher, which we've been projecting in prior trustees reports, or might it actually stabilize at something lower than that? Prevalence of disability really ultimately is the key, because that's the number of people who we're deeming who will be not only self-perceived to be disabled in our population, but such that they are not able to find work and will come to us for benefits. And by the way, benefits are not something that everybody wants to seek. If in fact you can work, generally the benefits the Social Security Disability Insurance provides are only about half of what the earnings level of people have been before that. So if you continue to work, people tend to go that way. Now, on the next slide, we have another look at what we are projecting now compared to where we were back on our 2008 trustees report. That's when we were projecting back up, at a 5.0 or higher incidence rate into the future. Looking at our population at the time, we were projecting that the number of people receiving disabled worker benefits would be rising up from roughly a 2016 level of about 9 million up to about 10 million and sort of stabilizing at that level. You can see where we are now. We have come down dramatically below that in the number of people receiving disabled worker benefits, and are projecting in the red line for our 2023 trustees report to be going back up somewhat from that. But again, the gigantic question is have fundamental things changed in our population, that people's self-perceived perception of disability and their ability to find work, which provides more income than our benefits, have things been changing? So on that count, let me ask that we go to the next slide, and Mike is going to talk some about some really, really interesting stuff that he's been developing that may shed a bit of light on this into the future.
Yeah, thanks. So this slide is showing some interesting data that we have about the shares of new disabled worker entitlements by what their primary impairment is. And this is specifically for individuals who are newly entitled between ages 30 and 39. And we have another age group on the next slide that we'll get into in a minute. On this slide, women are on the left panel and men are on the right. And so what this is really showing is some major groupings of different impairments and the relative shares of all new entitlements in a given year. An important caveat about this, just real briefly, is that we're showing this data by the year of first entitlement to disability benefits. And because there's a lag between when the first month of retroactive entitlement occurs and the actual time of when benefits are awarded, because there is that process for determining disability, and then there's an appeals process as well, is that data are fairly incomplete past the vertical line there that you see at 2019. And so just try to keep in mind that that data is really incomplete past 2019. Some interesting observations about this age group. The experience by primary impairment has been fairly consistent over time. There's been some ups and downs and things. Mental disorders for this particular age group tend to dominate. That's the lighter green series that you see on the slide here. And you can also see, if you look up near the top of each of the slides, in the late 1980s through the 1990s, you can see the effects of the HIV and AIDS epidemic. And that's in the infectious and parasitic diseases category, the purplish series near the top of the chart. This is really especially apparent for men. Let's go to the next slide then. And so this is showing a very similar slide, except it's for the age group of 50 to 59 with women on the left, men on the right. So unlike ages 30 to 39 that we just looked at, musculoskeletal impairments tend to dominate this group. And we're actually seeing an increasing share of new entitlements at these ages that have musculoskeletal issues. Mental disorders here make up a fairly small share of new entitlements for this age group, at least compared to ages 30 to 39. You can see the cancer and cardiovascular disorders are relatively larger for this group compared to 30 to 39. I think that's the lower purple series and the light blue series there. So just some interesting observations there about what types of impairments are we seeing at some select age groups and how that differs by men versus women. So I think Steve here is going to wrap up our part by talking about some of the reasons that we've considered for decline in disability applications and incidents.
Thanks, Mike, and great. On the next panel, which is our last little slide for this segment, this is keeping in mind where the time is, the big question is, what should we be thinking about and foreseeing for the future of disability prevalence, applications, and incidents? Are we seeing that we are having and expecting to have a healthier population, therefore less disability? The prior panel on mortality didn't sound very optimistic about that. However, there are other considerations. Are we seeing a greater demand for workers given the changing age distribution of our population? We know the adult population is increasingly being over 65. Does that mean in order to find enough workers for all the things we need to get done in our society, are we going to have to be more accommodating, as we indicate here, by employers for people with some level of impairment? We see some indication of that actually going on now, and will that continue and maybe even expand in the future with our changing age distribution? We know we also have a more highly educated population, which tend to be in jobs that are less at risk for becoming disabled, perhaps. What will increased automation in the future mean in terms of the need for and the prevalence of physical jobs? The last couple items here are the changing distribution of jobs and occupations in the economy. This probably related to, again, the changing age distribution, but many other factors. And also one thing we talk about a lot and think about a lot is the changing nature of work and jobs. We'll have a little bit more of that in the next segment about work, but the changing nature of work and jobs, the kinds of risks people are exposed to, and the degree to which employers need to seek to accommodate workers and keep them on the job even when they have some level of impairments that in the past might have resulted in them replacing them with more capable, with less compromised individuals. What will the implications of that be for our disability in the future? How much of that is explaining what we're seeing today? Will that persist, or are we going to go back to much higher disability incidence rates? So with that, we're hoping our panelists will be able to share with us much more insight. Thank you, Conway.
Thank you, Steve. Thank you, Mike. So I'm glad we could begin this conversation with these trends. Incidence is falling, application rates are falling. And so I just want to remind the audience that these slides are available on our website if you want to use them as a reference. So let me kick it over to Alan Heineman.
Thank you, Conway, for moderating, and to Diane for the invitation to participate in this session today. Appreciate the opportunity to contribute, and already learned a lot from the speakers today. Also, thank you to Steve and Mike for setting the stage for our discussion. The very up-to-date stats you've got are thought-provoking. Just by way of a reminder, my research program is health services research, focuses on populations with chronic illness and disability. I also direct a postdoctoral fellowship program in health services outcome and measurement at Northwestern University. Next slide, please. By way of context, I've served for more than a dozen years on the National Academy's Standing Committee of Medical and Vocational Experts to advise SSA's disability programs. The charge is to assist the administration in improving its disability programs. Broadly, we surveil the field on issues related to disability, collect and analyze relevant data, provide discussions which engage SSA staff in different departments. One of the major foci of the committee has been on issues related to functional equivalence to the medical listings. We have medical, nursing, allied health expertise, and measurement experts broadly able to address how medical listings translate to functional equivalence, and also consideration of how those relate to job demands in different professions. I also had an opportunity to chair a study report on functional assessment for adults with disabilities just before the pandemic. The context of functional equivalence is where I'm coming from in providing the discussion day to help kick off this discussion. And what comes to mind is the image of a pole vaulter who's trying to scale a bar set at a specific height. Much like a worker experiences job demands at different levels, the expert pole vaulter is going to develop the skills and ability to have experience to get over progressively higher bars. Though a super high bar may not be necessary to do a specific job, as one considers the sequential decision process that SSA has in determining disability. Next slide, please. There are three of the questions we're asked to charge with that I'd like to reflect on in the moments I've got here. What are the implications of medical and technical advance on future disability incidence rates, implications for workplace flexibilities, and how will projections be affected if Congress makes changes to the program. And next slide, please. This graph illustrates work that we conducted as part of our Rehabilitation Research and Training Center on employment of people with physical disabilities. This reflects several hundred respondents in the Midwestern United States. Our goal was to identify client, employer, and context-related facilitators and barriers to employment after injury or illness. We did extensive pilot testing, cognitive testing to make sure that people would understand the questions, recruited through social media, through our former patients, but also reached broadly to ADA regional centers, the National Rehabilitation Information Center, and several consumer organizations that serve people with physical disabilities. Time frame for this was administration beginning in October of 2020. We didn't had to pivot because of the pandemic in terms of administration, but we were able to complete the project successfully over a 6-month period. What's illustrated here are respondents from about 350 individuals, 78% of whom were working. Eligibility criteria was that you had a work history and had a physical disability. So this is a mostly working sample. A neuromusculoskeletal disorder was reported by 81%. And noteworthy, 60% of respondents were able to ambulate without assistance of some device. When we asked them what facilitated employment, positive feedback about performance, support from a supervisor, acceptance of a disability from coworkers, and emotional support were the top, endorsed by over half. Interestingly, use of accommodations was just over 50%, and a variety of accommodations that may or may not be provided by an employer were relatively infrequent. Speaking as a psychologist, I was not expecting that the social environment features would be such prominent influences on employment facilitators for why people continued to work. Next slide, please. I'm not going to dive into all of the details of the findings, but in general, people were more likely to be working if they received support from a supervisor, reported emotional support, various aspects of their life, and received help with life tasks outside of work in some capacity. They were less likely to be working if they reported negative attitudes from supervisors or colleagues, encountered inaccessible work environments, or had work schedules that were inflexible. This study looked comprehensively at the personal and contextual factors associated with employment. I think these results provide insights into the importance of emotional and social supports for effective functioning in a work environment. What's needed now are novel approaches to developing supportive relationships with supervisors and coworkers. The next slide builds on this data. The citations at the bottom if you're interested in pursuing this. Preliminary work was developing disability phenotypes from those who completed the survey. The groups under disability phenotypes were having a high functional disability and physical, cognitive, emotional stability, and sensory domains. High physical disability only, or moderate cognitive and low physical disability. We've used both employee-related factors and job and workplace-related factors to predict use of accommodations. And as you can see here, where the error bar is less than 1.0 or greater than 1.0, job accommodations were more likely for workers with more than one diagnosis, who were mobile using a wheelchair, who were familiar with the job accommodations network, had union membership, or perceived high job demands. Interestingly, self-employed people, perhaps choosing to be self-employed because of the disability, were more likely to report job accommodations. They were less likely for workers with moderate cognitive and low physical disabilities. It's within that individual, the combination of some cognitive and physical disabilities, and also jobs that required considerable or extensive preparation. My takeaway is that it was both employee and job-related factors that are associated with receipt of job accommodations, and they provide essential information for designing and implementing interventions that help people with disabilities when seeking accommodations. The bottom of the line, back to that pole vaulter image, is we can adjust the height of that bar so that more people are able to work. The last slide showing data here. We also in parallel did a survey of Midwestern US companies about their experiences providing job accommodations. The general findings support earlier findings of employers that create an inclusive work environment generally are those that are more likely to provide accommodations. Job accommodating companies were, yes, more likely to incorporate universal design, have a process for people to declare that they have a disability, a process for employees to request accommodations, inform employees that they can request accommodations, and also provide training to managers. So my last slide next, back to those three questions. Technology, assistive technology, I think is increasingly important in helping people continue to work who want to work. Back to Steve's earlier point, I think is well taken. Work generally pays better than SSDI, and people want to work. They gain important benefits, not just income, but in terms of identity, and in terms of belongingness within a community. Flexible hours, the opportunity to work remotely certainly can mitigate the effects of functional limitations. Bottom line, job accommodations enhance employment, and I think will result in reduced SSDI applications. One of our projects is looking at develop a decision aid to help people decide whether and how to request job accommodations. This is something that most people find pretty daunting, have no experience with, don't know what their rights are. And I think it's a fruitful area of work to provide both education on the employee and employer side on how to request accommodations. That's the end of my prepared comments, and look forward to our upcoming conversation.
Thank you, Alan. And thank you for your service on the National Academy's standing panel for SSA. It's a really important endeavor, and we're happy to have your perspective here.
Thank you.
Chris Murray, on to you.
Thank you very much. And I'm going to again be drawing on the global burden of disease study, where we, in addition to the mortality cause of death part, tried to track the incidence and prevalence of major health states with reduced functioning. Very different perspective. It's not, we're not trying to model people who are choosing or want to leave the workforce. We're just getting at the underlying rates of disease. Next slide. So our forecasts for health states, which we then use people's weighting of how severe they are to calculate this metric called years lived with disability. Again, not the same definition as used by the Social Security Agency. I'd have to say the modeling reflects for diseases that cause considerable mortality and disability, are the same risk factors are going to influence the results, but then there's a whole class of outcomes like depression, generalized anxiety, osteoarthritis, rheumatoid arthritis, which are mostly being driven by much simpler statistical models projected into the future, because we don't have very strong drivers. The very important exception to that for musculoskeletal disorders, which you saw is a rising share of claims, and we see in many data sources the rise of MSK. Obesity is an important driver of MSK and the increase we expect to see in MSK. Next slide. So this is just sort of reinforcing what I said, which is we have these sort of three-tiered approach. One is where we're going from death to likely incidence, or death for cancer, for example, death to prevalence, or the direct modeling. Next slide. And here's our very simplistic, naive statistical model for those where we don't have the relationships that I talked about, where we're really just capturing the prevalence for things like depression as a function of socioeconomic status and not much else. Now, occasionally, depending on the cause, we will stick in other drivers. For example, we will stick in obesity for MSK. Next slide. So what do we see? This is our measure, years lived with disability. These are counts, and these are select states, US nationally on the left, Minnesota, California, New York, and West Virginia. I just picked four, no particular reason. And so this does reflect the volume of people with considerable reduced function by cause. And you can see the red part is MSK, and the numbers go up because of aging and because of obesity. You see substance abuse in the sort of salmon color. And then cardiovascular disease, interestingly, on the numbers, again, that's an aging effect, are going up. Next slide, same story, but now showing you age standardized rates. And depending on the state, we're seeing the age standardized rates. So very at odds with the disability claims data that we were looking at, but we're seeing in our assessment of what's the past and what's likely to occur in terms of just the volume of functional loss, declines in some causes, like, very stable numbers for mental disorders. So that's important because that's an important trend. Stable numbers for neurological disorders in terms of age standardized rates. Some increase, but the big increase there is substance abuse. Again, the big question there that we had in the last session is, will the current fentanyl-driven epidemic burn itself out? We have not factored that into our modeling. And then you can see the age standardized rates for diabetes are going up. That's driven by obesity. And MSK, a little increase driven by obesity. Next slide. So we roll our assessments of disability and life expectancy into a summary measure, which is sort of overall healthy lifespan, called healthy life expectancy. And our numbers for healthy life expectancy, so now this is a reflection of both what's happening to life expectancy, but also those trends on the age-specific rates show declines in healthy life expectancy in the future. That is very, very dominated by, in terms of the healthy life expectancy part, by what's going to happen to substance abuse, which is incredibly hard to forecast. And I'll be the first to admit that we have not a huge amount of confidence that we can figure that out. And very likely, just assuming the rates stay constant is probably a more credible assumption than assuming they continue to go up. But that's what our models show. Now, the next slide just shows you a head-to-head comparison of I dropped that to save time. But basically, stay on the healthy life expectancy for a second. The healthy life expectancy looks more pessimistic than life expectancy because in addition to the things that are slowing down, like obesity and substance abuse, life expectancy improvement, we're seeing these increases in MSK and substance abuse and diabetes. Okay, next slide. And just to flag this, what I did mention in the previous panel, we have an ongoing effort to try to bring some of these assessments, ultimately all of them, down to the race county level, because we see such huge variation across counties and race ethnicity groups in some of these key drivers, like obesity, like substance abuse, and then the associated things like diabetes. So it's a very different picture, if you look at the extremes, comparing, let's say, Summit County in Colorado, than what we're seeing in, the sort of Four Corners, where there's been very severe effects of a number of factors coming together. Next slide. I think that might be the end. Is there one more slide? No, thank you. So that's our take. We have not tried to model the part that you're concerned about people making claims on disability, just the background health status trends. Thank you.
Thank you, Chris. Appreciate it. I think that it's a great segue between mortality and disability. I participate on the last one, but disability death rates are an important assumption. So I know, to go a little out of order, I know that you have a hard stop now at 12:30. So I just want to pose one question to you and ask the board members if they have any questions, and then we'll go to David, if that's all right. The broad question is, can you summarize how the experience in the United States is different from other countries? And in the last session, we got a question from Wendell Primus that I think relates to this, and it's, why is the trend in the US so much different in other countries given the spending? I don't know if you can weigh in on that, but United States versus international comparisons is the question.
Sure. What stands out in the U.S., especially on the disability side, is more severe. Although there's countries in Europe that are starting to see this, Australia, New Zealand, on the substance abuse front. So we're much larger impacts than other countries. Number two, we are farther ahead in the obesity epidemic. Other countries are well on their way to catching up, right? The trends are all the same. We're just about 30 years ahead on that epidemic. And so we're having more consequences. But we do expect to see those same consequences start to show up in other high-income countries and even some middle-income countries. I think that's sort of how, we're not seeing age-specific trends in mental health disorders, other big cause of disability, pretty much anywhere. We can debate autism, we can debate some very specific things, and a lot of it turns on the interpretation of the data, but in aggregate, we don't see age standardized rates changing much. We see a lot of variation geographically, but not time trends. So in terms of what's making things better or worse, a number of the chronic conditions like COPD that are tobacco related are improving, and they're improving all over the place. So if you try to piece together, why does the US look so bad, which very much it does, you've got to think about a background of more disparity by race, ethnicity, socioeconomic status than many other places. The farther ahead in the obesity epidemic, a bigger substance abuse effect. And then we've had this, which other countries have only started to show up now, this rise in adolescent and other age group suicide. But that's actually started to show up recently in parts of Europe as well. So I think we look bad, but other countries may unfortunately be starting to look like us as we go out 10, 20 years in the future.
Got it. Thank you. So I think at this point, I'm not sure if there's any board questions at the time, so I'll just turn it over to.
I think there was a question from Steve.
Okay, so Nancy and Steve.
Well, Steve should go first. Go ahead, Steve. Steve or
Steve.
Wait. Yeah, Steve Goss here. You're referring to me?
Yes.
Great. Okay. Well, thanks. Yeah. Well, just a couple of quick things. Chris and Alan both raised some really excellent questions, and of course, I think Chris is speaking sort of to the prevalence of negative conditions, of impairments for people in the population. And I think what Chris has presented suggests that we may be seeing somewhat more of that. Of course, accommodation by employers is really a key factor. And I would just mention, for example, back in the late 1970s, when the baby boomers were all surging into the labor force, employers were actually offering early out pension accommodation to higher age people because of the great surplus of people coming in at younger ages. We're actually seeing the opposite of that now, which probably is consistent with the concept that we're seeing more people working to higher ages and perhaps a higher accommodation, as I think Alan was referring to some extent. One other small item, I think, Chris, what you're pointing out in your projections are on the health status. A lot of this is drug abuse. Social Security many years ago reached the point where the simple, an inability and an impairment based solely on drug abuse and alcoholism actually does not qualify you for disability. Now, if it persists long enough, where you have cirrhosis or other bad conditions that in and of themselves will qualify you for disability, that is the case. But drug abuse that may be temporary and people can come back from is not ultimately going to be, it's not one of the drivers of disability now or in the future. Just want to sort of put that out there. So really the question is, do we see the kinds of impairments rising such that our workplace will not accommodate these? I think Alan and Chris both raised some very good points about what employers have been doing. And one way of accommodating, by the way, is to give people positive feedback about their work they're doing to encourage them to stay on the job, especially if you need them.
Nancy?
Well, I was just going to ask Chris, because I know you've got a hard stop, and it's been so helpful. We really appreciate you being here. And I really wanted to follow up on the international point, the stark difference. And of course, one huge difference between the United States and its industrialized counterparts is the availability of universal health insurance. Now, of course, the Affordable Care Act has helped that, but hasn't extended to nationwide health insurance. And to what extent does that really just reduce the severity of disabilities, or could it prevent disabilities from occurring and so forth?
It's such a hard question to dig into, right? Because clearly other systems, there's greater access to primary care. And so you would think rates of things that are treatable in primary care, for example, management of hypertension or management of high cholesterol, would be better in those systems. But it turns out to not necessarily be the case. The US, for example, does really well on managing cholesterol compared to Europe. And now part of that is not so much access, just more willingness to treat and use drugs in this country to manage these things in primary care. So as we try to dig the next level down and try to figure out, well, what's going on in primary care that could really make a difference, you do run up against it's a little bit harder to disentangle than you would have thought. I think we all have the idea that's got to matter, because sort of at the macros or the aggregate level, you see these relationships, better primary care, you better outcomes, but trying to figure out what's going on in that experience is a little bit harder to figure out.
Oh, very interesting. Thank you.
Thanks, Nancy. So let me turn it over to David.
Terrific. Well, what a fascinating morning. The first group of talks were super interesting, and the last two are also so interesting as well, particularly all about the impact of obesity, which to see manifest in the data in all sorts of ways. And I don't know if it breaks out things like NASH, non-alcoholic steatohepatitis, but that would also be interesting. So next slide. This is just my disclosures next. So next slide. So my whole career has really been focused, both engaged with and discussing a range of emerging technologies, from genetics and gene therapy things like digital health, AI. There were some questions in the chat on AI, and something that I think Steve brought up on synthetic biology regarding mRNA. The first graph of this review actually talks about the origins of Moderna and how initially, yeah, they were trying to use mRNA for something other than COVID, and with a lot less success. So it was exactly spot on. Next slide. What I really want to do today is to just do a brief vignette of the arc of molecular medicine, to sort of as an example of what it's like to try to kind of capture the value, in the sense of emerging technology and some of the challenges as you go through it. And then to take a step back and to say, okay, what is sort of the process like, so that we can kind of calibrate our expectations. So next slide. So for molecular medicine, let's start in the glorious 80s, where this is a pre-genome, human genome project, but there's a lot of discussion of it. And there was Sidney Brenner's famous South African-born biologist who said, well, if you had a complete DNA sequence in a big enough computer, you can compute the organism. Harvard biologist, big sequencer Wally Gilbert said, with a complete genome, we'll know what it is to be human. And there was so much excitement around this that it motivated another Harvard biologist, distinguished late Richard Lewontin, to sort of pen this famous New York Review of Books piece, essentially asking if everyone is just starting to sort of fetishize the human genome and to be excessively reductive about it. Next slide. But progress can, similarly, Brown and Goldstein of cholesterol fame emphasize that just because you have a sequence of something, it's not the same thing as having a medicine. However, next slide, research continued to pace. And with the event of medicine STI 571 Levac, there was a suggestion that, oh, molecular medicine, precision medicine has arrived. This is the ammunition in the war. These are the bullets. Everyone was super excited. But then it turned out it wasn't as generalizable as folks thought. And if you, next slide, flash forward back, you progress to 2008. And these are real headlines. There was a lot of despair. We fought cancer, and cancer won. Advances elusive. Almost sort of like a cancer, almost like a winter for cancer progress, it felt like. But then next slide, there was a new hope in the form of using the immune system to fight cancer. There was a lot of excitement. There was a Nobel Prize, a lot of progress associated with this. And in fact, now, next slide, there are so many different approaches that are being used, from gene editing, gene therapy, cell therapy, RNA therapeutics. The number of different modalities available to attack disease is just exploding, which is really, really exciting. Next slide. So we're seeing both all these modalities and also them being used in remarkable combinations. I mean, folks are dialing in and out of cells, all sorts of features and capabilities, and doing it, in an iterative fashion. It's remarkable. So all this progress has prompted even some at the New York Times to ask, next slide, are we entering the golden age of medicine? A lot of this seems really promising. Okay, next slide. So how do we think about calibrating expectations for technology? And the dilemma here, next slide, is that the way this is often done is sort of, we sort of get exposed to these extremes. AI, it's either more important than fire or electricity on the one hand, or New York Post, here comes the killbots. So maybe there's something in between. And in between all of these extremes, as we've seen from many of the talks already today, and next slide, which we've seen just in some of these classic images, there's real concrete evidence of progress in terms of prevention, from vaccines for smallpox, polio, and measles, just boom, making an incredible, palpable difference in those conditions, as well as medicines for antiretroviral medicines have dramatically, as you saw in one of those earlier slides, there was a bubble in one of those graphs that shows this tragic deaths, particularly of men from HIV, and a lot of that is decreased due to these medicines. So that's really palpable examples of progress. So we sort of need something in between. And if you go to the next slide, what you can see is that on the one hand, technology should matter. Powerful technologies can radically change science. You think about the impact of the microscope, the telescope, calculus. The new technologies are what enable us to ask different questions of nature, to improve how we understand it. They're profoundly enabling. And in fact, Sidney Brenner of the earlier slide even said at one point that progress in science depends upon techniques, discoveries, and ideas, probably in that order. So techniques are really important. And the whole point of this slide is that it isn't just the neomania that Taleb appropriately critiques. There's actually real value that can be obtained from new technology. Next slide. But this is the critical point. This is from a Grecian urn. New technology does not spring like Athena from Zeus's head, fully formed and like ready to fight. Just not how it works. Next slide. Rather, as Professor Colada Perez has described, there's a real sort of pattern to a technology revolution, whereas a technology arrives, as you can see on the left, and then basically there's this what she calls a speculative frenzy, but it's this whole period of chaos when people are trying to figure out like how to use it, what does it mean, how do you kind of get your head around it? And it's not for a very long time afterwards, if you're lucky, that you actually really start to eke out the productivity benefits from this. So people start to kind of understand how to leverage the technology and really use it productively. So the canonical example of this next slide is from the transition from steam to electric in factories. When steam-powered factories, they were built in this ultra-compact three-dimensional fashion to sort of minimize the distance from the single source of power. When electricity was swapped in, initially it had almost no impact on the total productivity. It was just essentially like a genetics, like a conservative substitution. What actually had to happen is someone had to progressively over time have the idea of reconfiguring the design of the factory, which took years to figure out and was actually done mostly by emerging industries, because unlike the legacy companies had all these sunk costs. They're like, well, we've already invested in factories looking like this. Whereas for new companies, they were sort of more willing to try something that could be better. And so next slide. The point is that coming up with something, an invention, isn't the same, like on the left here, it's a first car. It isn't the same thing as obviously what it comes to. But in order to go from for a technology to evolve, you also have to evolve the underlying infrastructure. Next slide. So you can see on the left, those were the roads that existed when the first car came around. And in order to sort of progress to something closer to our modern state, there was a lot of associative changes that were required. And so the key point, next slide, is that implementation is not instantaneous. This is from a wonderful book, by Boston University professor, economic historian, and successful entrepreneur Jim Besson, who wrote Learning by Doing. He has another book out, The New Goliath. But the point is that he points out that we often conflate invention and implementation, but in fact, most of the productivity gains from new technologies, you only get to them after decades and decades and decades of sort of futzing with it and kind of figuring out how to use it. This is a sort of an example from his book of just many different instances of this happening. So next slide. The point is that implementation takes time and lead users. Jim points out that major technologies typically go through very long periods of sequential innovation. Northwestern economic historian Robert Gordon has written in the context of transportation innovations that most of the benefits to the individuals didn't come immediately, didn't even come within a decade of the initial innovation, but you needed subsequent decades as subsidiary and complementary and all sorts of tweaks and and adjustments became manifest. And the last perspective on this that I think is really helpful is from MIT researcher Eric von Hippel, who emphasized that the key to applications are lead users, the folks who are just trying to solve a problem. And they just want to use the best approach that are available. And they're the ones who are going to really be taking something that's new and applying it. So next slide, just about done. So bottom line here is that we've lived through the hope, disappointment, and rebirth of the ongoing revolution in biology and molecular medicine. I could have gone through the exact same thing a little bit earlier stage, I would say. I took out those slides in the interest of time, but of the digital and data revolution and AI. But we are living through the early days of this revolution. And the interesting thing is no one knows. No one knows. Like you look at all these consultants with their, detailed projections, and no one knows how new tech will play out. Edison, when he invented the phonograph, he kind of anticipated it might be used to record wills and sermons. So it's very difficult. I'm sure Facebook didn't expect that they were going to obsolete sort of the newspaper advertising business, but all of this stuff happened. So it's really hard to predict. Its prediction about figuring out the new technology and figuring out how to really get the value from it is hard. It takes a long time and it requires all sorts of tweaks and iterative innovations and a group of engaged lead users who are really focused on doing this. But ultimately, I would argue that this process is worth it because new technologies really can be incredibly powerful tools for medicine. Two quick last slides, and I think next slide. So we've seen versions of this already. That in general things are getting better, or at least I thought they were before a slide from the last presentation with 18,000 variables that projected out and showed, well, maybe things aren't going to continue to get better. But I feel like this is I like the trend here, and I'm hopeful that the upward trend can continue. And the last point from the last slide is that coming up with new things is really, really hard. New inventions are fragile, they're easy to critique, and they don't work right initially. And as they said in this Pixar movie, the new needs friends. So that's back to you in the studio.
Thank you, David. I appreciate it. I think we're really lucky to have three distinct perspectives coming in at this. Physician economist, physician scientist, psychologist. This has just been really, really interesting. So thank you, David, for helping us set our expectations about the impacts of emerging technologies. Let me also ask Steve and Mike to join us, and I'll give you the opportunity to provide any responses or initial questions to David and Alan.
Thanks, Conway. Let me start. Well, Mike, why don't you take it away here, and you get the start on this one.
Just an observation that I found all the presentations very, very interesting, and certainly gives us some new things to think about, especially the aspects about the effects of technology and medical advances. Certainly something to think about, not just in terms of disability, but also on employment.
Thank you, Mike.
Great, thanks, Mike. You let me just add, if I may. I mean, we clearly have a real tension here in terms of disability, and one of the things that I know we've thought about a lot in our shop relative to mortality in the past, but it applies as well as to disability, and perhaps maybe sort of in the realm of what David's talking about to a great extent. We've always talked to mortality about the extent to which we can reduce mortality either by really creating a literally healthier population that's less likely to die, or by creating mitigating interventions to take people who are not so healthy and keep them from dying. And it sounds like we have something very similar here that, David, I think you might be getting at in the area of disability. We have maybe a certain level of underlying maybe physiological impairment or deterioration that goes on. Then there's the question is, can we, through interventions, through technologies, maybe mitigate, reduce, or create accommodations for such? So is it possible? Our first panel, as we all saw, on mortality here was not very optimistic in terms of mortality and health level. But David, are you suggesting that maybe through interventions, technologies, not the phonograph anymore, but perhaps AI or whatever, that we might be able to have even greater accommodation?
Well, I guess what I would say is I'd advocate for a non-magical view where people have this view of, like, AI in particular, that it's going to descend from the heavens like Deus Ex Machina and solve what ails you, and that isn't how it works. I mean, I guess what's very interesting is if you look at how technology has impacted health, even in the example of COVID, when you look at, for example, how technology helped the evolution of like the Pfizer vaccine set. I have nothing to do with Pfizer, it's just like, it's like been written about. It actually was the fact that the digital and data enabled a management tool. It was by providing visibility into where every aspect of the process was, it enabled people to sort of produce the medicine better and to address issues sooner. I think a lot of the technology for digital health, I was so intrigued by Alan's points, where what seemed to be most impactful for the people were the humanistic components, if I understood it right. The positive feedback, the sense of respect, and it works. And if technology can help convey the real personal, that I don't think that, oh, having a computer is like, you did a good job. But I think the idea of enabling people to communicate, to impart that communication and to share in that relationship with somebody who might have a more difficult time coming into work, or might have to work with different accommodations. But I think it's really the human connection. I don't want, I suspect Alan doesn't need anyone to speak for him, but I thought that aspect of it was the most among many intriguing aspects. And if technology can facilitate that relationship, that seems really valuable, versus technology just coming in and solving something sort of in and of itself.
Alan, do you want to respond to anything?
Well, thank you, Dave, for that comment. Technology is certainly important, whether it's medical advances, genomics, whatnot, more mundane things like computer keyboards and mice and visual accommodations, but ultimately work happens in a social context, and feeling like you belong and are valued is incredibly important. And there's a incredible naivete, lack of experience on most workers' parts when impairment, disability intrudes, and they don't know how to navigate the system. DI application typically is not the first thing they think about. It's how can I continue to work? There's certainly situations where mental illness, substance abuse, and an unrewarding job certainly can limit, but really must consider the social context within which work occurs.
Ellen, could I just ask one further question with respect to the kinds of feedback issues you mentioned? Is it possible that we're moving into a period, we've been in a period for a while now because of the changing age distribution of the population, with so many boomers getting older and leaving the workforce, that in fact, one way of accommodating by employers to encourage people to stay on the job, maybe we even have some more limitations, is to give them positive feedback? I mean, I assume that, and I assume that when you're talking about accommodation, you mean like, providing, different kinds of physical settings, et cetera, et cetera. But I mean, where if you had 1 million people standing at the door willing to work for nothing at your job, you may not give such good positive feedback to people who are, for whatever reason, underperforming. But on the other hand, if you don't have a lot of applicants coming in to do the work, you're probably going to be more, not only more accommodating, but also more positive in the feedback. Do you think that's any aspect that we're seeing now in terms of people staying at the job, not applying for disability?
I think that's part of it. Yeah, macroeconomic factors certainly are important. Certainly increase of pay in the last few years, so that's partially offset by inflationary pressures. I think employers have come to realize, I don't want to speak too broadly, but that when they've made an investment in a worker who knows the basic job skills, having to lose them and start fresh with a new hire is a huge cost. So it's good for business to retain the people you have and provide support and education and feedback to do the job effectively.
Thank you. So at this point, I'll ask the board members to join me on screen, and I'll see if they have any questions. Any first takers?
Hi, Conwells. I'll jump in. It seems to me that where this conversation has been going is that that advancement in technology, both in terms of medical technology and others, have allowed people to be more functional, and I think that's fantastic. I still think, given that our model in some places is that in order to access those very services, those medical services, assistive technology, auxiliary aids and services, you need to get on disability. You need to become eligible for SSI or SSDI in order to access the types of resources that would allow you to get the to get that other types of assistance. So I'm wondering if some of the implications of what you're saying would affect sort of overall social policy in terms of how we support people to stay in the workplace.
I can take a stab at that, which is that most job accommodations are not particularly expensive. I don't recall the national estimates from the Job Accommodation Network, but they're not more than a couple $100s for the most part. They are typically employer funded, not by an external entity. Certainly, assistive technology can be provided as part of the vocational rehabilitation process, whether that's a state federal system or whether that's a private disability plan. And certainly the progression from short-term to longer-term disability, insurers, private insurers and employers have an incentive to keep people in the job and not go through the expense and hassle of paying on a disability plan and replacing the employee. So I think it's important to distinguish between the relatively affordable accommodations that employers typically self-fund versus those that are paid as part of a vocational rehabilitation service plan or post DI award with the incentives to consider return to work. My hope is certainly that people would be accommodated earlier in the process rather than get to the point of being awarded benefits and then, oh, by the way, you're eligible for the trial work period.
And then the variation of that is, in terms of getting accommodated early, the ultimate thing is what David was talking about in the earlier session about prevention. So if you're able to, he was talking about prevent, like, you don't smoke and your chances of getting lung cancer are lower. But for some chronic diseases that no one knows why one gets, or that are bad, just bad luck with genetics, if you are started on effective treatment earlier, like for cystic fibrosis, that's a phenomenal example where the mean age of death, I was just looking at the data earlier today, about a decade and a half ago, was 22. And now it's like 66, not as good as it should be as sort of the average for the population, but going from 22 to 66 is phenomenal. And the opportunity to all of a sudden be in the workplace and to be relatively, certainly a lot more healthy in the workplace. And I think that there are other examples of that where diseases are kept, in abatement longer because of so people's need for any type of additional accommodation other than having their actual disease kept in remission. You could even argue in some sense HIV might be like that, with the medicine keeps one's disease, so you're below the lower limit of detection, then you're not, then your chance of having HIV related sequelae are a lot lower.
And Conway, I'm happy to jump in with a question.
Please.
And that is, we've been talking, the as we all know, that sharp drop off unanticipated in applications, it's really stark. We've been talking about possible positive reasons for that, the accommodations at work and so forth. I'd like to talk about the other side and what might be discouraging people from applying. There's, the large backlogs, the low awards, which have been publicized both in media and I'm sure it's word of mouth. There's especially a decade ago, but still the demonization, accusations of fraud and so forth of people who are receiving disability, and the complexity of the process, particularly for people may have mental health issues, other issues that make it very hard to go through the process. Are those, I'm just sort of curious what your reaction is to that side of the equation and whether, and if so, that is a whole different set of policy prescriptions, more funding to get the backlogs down and so forth.
I think Alan may have a deep perspective on what the folks are thinking. To take a tiny aspect of that, Nancy, I do think technologies like even some of the generative AI might play a role, a small role in helping make some of the interaction with the system possibly more user-friendly. And that's a real opportunity. Many organizations are trying to use AI, Gen AI mediated approaches to make interactions simpler and more intuitive. And I think that's going to, that's where a huge amount of work is now. I don't think the answer to the world are chatbots, but I think to the extent that, generative AI has this remarkable ability to kind of understand the complexity of a domain and be able to at least express the complexity in a way, even often correctly, that reflects the large amount of information. So I can imagine that could be somewhat helpful and should be done. There's been so much great advances in user experience that isn't always manifested in the way people are left to interact with many medical and disability systems.
Nancy, my take on the downturn in applications reflects the incredible changes that occurred as a result of the pandemic, where remote work and flexible work hours have become the norm for so many people. That's been such an advantage for people with disabilities, particularly with mobility limitations, or who have reduced stamina that need extra work breaks. The ability to work from home, the ability to adjust hours, those are the lowest cost accommodations to employers. And we discovered rather abruptly that the economy keeps chugging along very nicely, thank you, with able-bodied people appreciating those accommodations. It supports work-life balance, parents. I think it's an incredible natural experiment in demonstrating the boon to people with disabilities.
Yeah, that's interesting. Of course, it started before that, but you're exactly right. And this event today is a good example of the ability of people to join.
As much as I would like to have seen you in person, this was very convenient.
Yes, we were happy to have our three panelists from 3 different time zones join us today. Amy, did you have a question, or Jagadish? Offer that opportunity.
Sure, yeah. So, again, on this issue of the decline in applications and incidence rates started way back in 2010. So although I agree that COVID-related remote work possibilities have become the norm and may have assisted people who have work-related disabilities, I think you still need to explain why the long, now almost secular trend since 2010 has occurred. And my question is it possible? I don't know if this kind of investigation has been done. Is it possible to actually distinguish between people with work-related disabilities who are more likely, controlling for age and so on, to apply for SSDI versus those who are more likely to remain working or otherwise not apply for SSDI, and to examine those who are more likely to apply for SSDI, why they have not applied, and if they've not applied for SSDI, what are they doing? How are they supporting themselves? Is there any such possibility for investigating, what is the cohort or the distinguishing features of folks who we think would have applied based on prior data, but who have not applied, and how are they supporting themselves, or what their current situation is? That's kind of a general question. Maybe there's no answer, but I thought I'd throw that out. Thank you.
I hope there's somebody participating from SSA with program experience that is able to address that question.
Yeah, Steve Gross here. Let me just mention very quickly, and Mike Stevens can speak to sort of what I think has been a fairly uniform decline in disability applications by geography and by other characteristics. So it's really been quite consistent across. So it does seem that this has been really going on. And it is true that, we dropped by 2019, our disability incidence rate dropped from about the 5 per thousand level that it had been at down to about 4 per thousand. which that was even before COVID was around. So that was quite striking, really, as Jagadish was suggesting. Now it's dropped further to about 3 in the pandemic. But what's interesting is even with our field offices having reopened April of last year, well over a year now, for the opportunity for people to come in and file for disability in the old way, we still have not been seeing really any kind of dramatic increase in applications. So Ellen's points about accommodation in the workplace in many, many ways seem really to speak strongly to this. And the question is, do we anticipate this sticking for the future?
You are right, Steve, that, I mean, across a number of demographic dimensions that we've looked at, is that the decline is very similar across things like age, sex, geography, type of impairment, educational level, et cetera. So that's really striking, I think. And the other thing that I had mentioned earlier is the fact that SSI children, who have a very different definition of disability and have very different types of impairments, are also experiencing very similar declines as we are for adults. And the other thing I just wanted to mention, we keep saying that the decline has been remarkable since 2010, but remember 2010 was overly inflated because of the effects of the recession. So we naturally would expect a decline from 2010. The remarkable thing has been that it's declined well below what we had been experiencing before the recession. And that's really what needs to be explained here. In terms of what Jagadish was asking, is, that's a really interesting question. I'm not aware of any data that's like readily available to answer that type of question. It seems like that would be a really fascinating survey for someone to do.
An additional data point is the increased employment rate of working age adults with disabilities over the last 3 years. It's improved more than in the general non-disabled population. My hunch is that there's a large pool of people with work experience with disabilities who want to work that are waiting to come in when as accommodations become more prevalent. It's a huge untapped part of our labor pool.
And Alan, we actually have a slide in the next panel that we almost included in this panel as well. So please, I hope you'll stay tuned.
I will stay tuned. Thank you.
Thanks for that plug, Steve. Amy, question?
Yeah, so I'm happy to close this out, and sorry that Dr. Murray had to leave us early, because I am going to go back to his points earlier about the county level analysis, and we'll pick on Steve and Michael a little bit here. I'm interested in, given what he showed us around health disparities, how that aligns with agency data on disability beneficiaries by geography, because we know that it's not consistent in regions of the country. And so I'm just interested in if you all have looked at this, and he noted that he had not done the analysis yet, but perhaps that's an opportunity for OAC to step in here.
And Mike, I don't know if you want to speak on that. I think Mike has looked fairly carefully, I believe, at least the state level on this, and where undoubtedly death rates, employment rates, disability rates vary. The question is, have they been sort of maintaining the same relative relationships? And I think, Mike, you indicated that has been kind of the case.
Yeah, so we have looked at applications by state, actually, at the state level, and it's been declining at a fairly steady rate for all states. I mean, certainly some states have been declining less or more than others. And a large part of that is because some states have very few applications. Like, I'll pick on North Dakota because I have family there. It's easy to get a lot of variability in a state like that with very few residents. But generally, most states are experiencing declines at very similar levels.
And another factor on that.
Sorry, Steve, just
go ahead,
follow-up question. Yeah, a follow-up question, because I know we are all mindful of the definition of disability being unable to do any job that exists in the national economy. And so there's certainly a bit of a tension there when looking at state level analysis versus a national program. What can you all share with us about how you think about the projections in this type of data when you're trying to develop the projections for the trustees report?
Are you talking about the state variation?
Yes.
How we think about that relative to long-term projections?
Right, recognizing that the definition of disability is a national one.
Well, one of the things we do try to take into account literally is the changing distribution of employment, again, which we'll get a little bit more into in the next panel. I mean, as several have mentioned here, I think Alan in particular, that you know, with accommodations, the nature of work in many areas has really changed, such that people who might not have been able to continue to work in that area perhaps can now. And really the question is, how is that going to be evolving into the future? That doesn't necessarily mean that those individuals are in general healthier and will live longer, but it might be that they will be able to remain able to work in something that's available in the economy, as you point out, Amy.
Thank you. I just wanted to editorialize that perhaps David's point about the length of time it takes for technology to find its sweet spot could apply to public policy like the Americans with Disabilities Act.
That's a point well taken. Passed decades ago and still implementation challenges.
So I did have one other question I do want to ask David before we wrap up. I'll take the extra little 5 minutes that we took out. But for David, you know, there was tremendous international collaboration during COVID on the vaccine development. Is that same level of collaboration in medicine going to continue?
Yeah, I mean, I think so. If you look at one of the fascinating parts to your exact point, Conway, about the rapid development of the remarkably rapid development of the COVID vaccines, when folks have looked at it and said, well, how did you take this thing that typically takes 14 or 15 years to develop and do it in about a year? And there have been longer examples. I mean, there's some GI vaccines that have taken 35 years to develop. So this was remarkable. And in general, actually, one of the key factors was a huge amount of investment at risk. But another factor was that the two big factors were actually investing at risk, like assuming a stage is going to work and then doing the next stage versus waiting to see how it goes. And then the next part of it that was with regulatory and the sort of the collaborative aspect that you described, not just the FDA, but it was like all the people, it was a real kumbaya moment where all the nations of the world like holding hands, and even the medical centers, and everybody was really united. And so often it can take a long time, understandably, with IRBs and with all sorts of back and forth and dialogue and more dialogue. But here, the benefit risk was such that people were so excited about it that played an incredibly, a monumental role in accelerating. So I think it's incredibly frustrating at some level for folks with, who are suffering from rare disease, who are suffering from cancer, from other situations. They're like, okay, that's great what you did with COVID, good for you. But what about for this? Can we collaborate? To your point, can we do this? And I think it should serve as an example of what's possible. But I think the speed unnerved clearly a lot of folks. And I'm hopeful. One of the things, so I served on this National Academy of Medicine panel about digital data and COVID. I co-led with Amy Abernethy, Deputy Director of the FDA, and Peter Lee. And basically, one of the things that we really concluded was there was a huge amount of real last mile issues in terms of being able to actually get the data that folks needed to really make decisions. And a lot of the issues aren't even technology. It's all like people not wanting to share or people wanting to collect things in certain ways. So for a lot of the ultimate issues, you're more right than you may even really appreciate is we often see the manifestation expressed in terms of technology or technology challenges, but it's not like there isn't technology available to do the job. It's really it's really the human factors, all of us, and being able to collaborate better and more fully for a greater good.
Thank you for that. I appreciate it. Alan, any last thoughts, or is that a good way to end it?
I think that's a good way to wrap it, Conway. Thank you.
Good. Well, thank you both. Thank you to Chris, who can't be here at the moment. But we're just really thankful for all of your perspectives that were shared today. And also to Mike and Steve for their participation and partnership in this event. I'd like to thank the audience as well for their engagement and questions and comments. And feedback on both of these sessions and the next one is welcome and can be emailed to us at events@ssab.gov. So just briefly, a few logistics before we turn. We will adjourn for an hour for lunch, and we'll return at 2 p.m. Eastern, or breakfast, I guess, depending on where you're at. But we will resume with the final panel on the future of work. So please feel free to keep the meeting open, or you can leave and rejoin. But we hope that you return for our third panel, which will, I think, tie in these issues in an interesting way. So thanks, and see y'all soon.
Good afternoon, everyone. Welcome to our third session today on the future of work. Thank you all for joining us today. A short disclaimer before we get started. The information presented here is for the purpose of informing the board. The views expressed do not necessarily reflect the views of the board or any board member. We are recording today's session. You will be able to access it on our website at ssab.gov. Questions and comments are welcomed and encouraged and can be submitted through the Zoom Q&A function, or you can email us at events@ssab.gov. You can also tweet us using our handle @ssabgov. Feedback is also welcome and can be sent by email to events@ssab.gov. My name is Emily Rosell. I'm a senior policy researcher here at the Social Security Advisory Board, and I'll be moderating this panel. The objective of this event is to hear perspectives from a range of experts focusing on mortality, disability, and work, and discuss the implications of current knowledge to inform future trust fund assumptions. This panel will discuss expectations around the changing nature of work and why it is particularly uncertain. People qualify for OASI and DI by contributing to the Social Security trust funds through taxes on their earnings from covered jobs. What work will look like is critical to understanding program contributions and costs. I'll start off by introducing our panelists. Then SSA's Office of the Chief Actuary will give a brief presentation, setting the stage for today's discussion. Each panelist will then give opening remarks, followed by a moderated discussion with the actuaries and our panelists. Just a reminder that full bios for our panelists are posted on SSAB's website. Stephen Goss has been the Chief Actuary at SSA since 2001. He has worked in areas related to health insurance and long-term care insurance, as well as pension, disability, and survivor protection. Karen Glenn is the Deputy Chief Actuary for Long-Range Actuarial Estimates at SSA. She is responsible for the demographic and economic assumptions that underlie the 75-year estimates of the cost of the Social Security program, as well as for the long-range cost estimates of Social Security. Stepitsa Mudrazea is an assistant professor in the Department of Health Systems and Population Health at the University of Washington and a non-resident fellow at the Urban Institute. He studies issues related to population aging, intergenerational support, and the health and well-being of older adults in the US and internationally. Stephen Popper is a senior economist at the Rand Corporation and professor at the Pardee Rand Graduate School. He currently works on decision-making under deep uncertainty, science and technology policy, and security planning. Shelley Stewart serves as director of the Future of Work Initiative, a part of the Economic Opportunities Program at the Aspen Institute. She has studied the changing nature of work for more than 10 years and is an expert on non-standard work arrangements and the gig economy. Now I'll turn it over to Steve and Karen for their presentation.
Thank you, Emily. Let me start on the next slide, if I may, and then Karen and I will go back and forth a little bit on this. And thank you so much for setting this up, Emily, and the rest of the folks from the SSAB. And by the way, I'm hoping that everybody here on the panel and elsewhere were on for the couple of earlier sessions that we had earlier today. There was much discussion in the last session about disability that really relates very directly to the nature of work. A lot of discussion of workplace accommodation and many other aspects about the changing age distribution and other aspects of our population. So if we can flip to the next slide. Thank you very much. This is something that we've been looking at for some time now, partly in the realm of disability consideration, but also just in terms of looking at work in general. As Emily well described, being employed, working, having earnings, and having payroll taxes paid on them is the basis for people being insured for Social Security benefits and determining the level of the benefits. And then when they're not working, that's when the benefits kick in. So employment is really everything. Now, what we have here is some material from BLS showing over the period of the last 20 years the changing distribution of workers by occupation. And it's really quite striking. We've had a big increase in the number of people in management, professional occupations, and we've been relatively flat or even declining in most of the other areas. Service has been going up somewhat, but in a lot of the areas like natural resources, construction, et cetera, some of the sort of higher risk physical jobs, they've actually been flat to even possibly declining in some cases. So the changing distribution of employment certainly speaks to sort of the nature of the work in the context that we're interested for the purpose of Social Security. Where are the jobs? Where are people employed? And the question is this a new level, or are we going to continue moving in these directions? That's one of the questions we have. So on the next slide, please. This is not quite as directly related, but just to give you another interesting sense that relates to this, the shift in the men versus women composition of our workforce, of employment. And you can see here, the first two bars in each of these segments will show you the difference from going from 1970 to 1990. And you can see for men, the employment rates, that is the ratio of employment to population for the particular age segment indicated, typically declined at some ages more than others for men. But for women, there was a dramatic increase in employment rates between 1970 and 1990 at some of the older ages, maybe not until a little bit later. So we've had a dramatic shift by gender, by sex in the population for our workforce. And that has probably contributed to some degree for what we saw on the first slide. So what we're really interested in here for so very, very many reasons is the changing nature of work, not just in terms of the types of jobs, but also one other thing I would throw in that we talked about a bit on the prior panel is the changing age distribution of our population with fewer people at ages, say, 25 to 64 compared to the entire adult population. Will that put extra demand for workers in the traditional ages and to higher ages yet? And with that, let me pass the baton to Karen, because I think Karen actually has some answers.
Thanks, Steve. If we could move on to the next slide. Great. This is just a different way of looking at that employment data, sort of a different cut at it. Each line you see on these graphs is for a different age group. Going from 1990 to 2022, you'll see the panel for men on the left and women on the right. Age group 25 to 54, so that broad age group is at the top. And you can see that each successive age group has a lower employment population ratio. A few things to note on these graphs. You can see the large drop off for most age groups following the 2007 to 09 recession, and then the very gradual rise back. Also, you can see very clearly the effects of the 2020 recession following the pandemic. There you see a very quick recovery in contrast to the prior recession. More broadly, over time, you can see that age groups 60 to 64, 65 to 69, and 70 and older have all been increasing. And this relates somewhat back to our disability discussion this morning. How much of this shift is due to the changing demands on workers, accommodations by employers? And as the age distribution of the population continues to change, and we've got more people at those older ages, will these trends continue? Next slide, please. This one focuses on the quits rate. So the quits rate, many of you are probably familiar with, is a measure of how many employees voluntarily leave their jobs. And on this graph, the quits rate is the dashed red line. And the blue line is the employment to population ratio. This is all workers, all people age 16 and older. And again, these rates are age sex adjusted. You can see that the quits rate really tracked the E to pop ratio very well up until we got to the pandemic. After that, things changed. So in general, a high quits rate means there's an increased demand for workers, which is what we've been seeing recently. The question we've got is, will this relationship settle back to its old pattern, or is this really the new normal? Will there be a deviation between the two rates? Next slide, please. This turns to a couple of graphs we just put together recently and was mentioned in the previous panel. This is employment by disability status. So one thing to note, first of all of this data is based on self-reported disability status as reported in the current population survey. So it is not the same as the definition we use for Social Security disability benefits. So just keep that in mind. The top graph here shows a few stats through time. First, the blue line near the bottom shows the percent who are self-reporting as disabled. And as you can see, since 2008 until the present, that's been really stable. Maybe a very slight tick up in the past couple of years, but it's really been at around 7 to 8% for all that time. The yellow line shows the unemployment rate for the same group, those who self-report as disabled. Obviously, the pandemic spike jumps out in early 2020. The really most interesting thing to take away from this graph, though, is the gray and the orange lines. The gray is labor force participation, and the orange line is the employment to population ratio we've shown you in some previous graphs. Both of these lines have been trending up noticeably since about 2013, and even more so in the last couple of years. So clearly something is going on so that people who believe themselves to be disabled are working more. The bottom graph, this is folks who do not report themselves as disabled. And you can clearly see that there is no similar rise in employment over those same years. So questions we've got for the future. Will those employment rates for the disabled population continue to increase? Will they level out or something else? And with that, let me turn it back to Steve.
Great. Thank you, Karen. And on our last little slide, we just have a couple of the questions that we're wrestling with. Karen alluded to at least a couple of those I might have earlier also. One is there's much talk about AI, and we're also going to have further automation in many, many areas, robotics, et cetera, et cetera. This diminished the need and demand for human beings to actually be working. We note, of course, that mechanization of farming way back when, industrialization did not. We seem to always find a place where human beings can still engage and contribute productively. And when do we not want more production so we can have more consumption? A second point is, will we continue to move towards having jobs be less physically demanding and less dangerous, thus allowing workers to work longer and to older ages? Effective infrastructure, immigration, climate change may all have something to say about this, but these are trends which have been going on for a while now, as we've seen from the graphs Karen was showing on the prior slide. And where are we going in the future? Part of this really is, again, a matter of the changing age distribution of our population. Will there be an increasing demand for people at higher ages to work longer, first of all, because they can, second of all, because of the changing nature of work, and also because of relatively fewer people at young age as compared to 20 or 30 years ago. And finally, even if we have automation and AI, we'll still require human production, maintenance, and design for the foreseeable future for these entities in all likelihood. automated work, even no matter how much that is, we're still going to have ways in which people will contribute and people will be required for that. We've seen the Industrial Revolution in the past. A lot of people thought, well, perhaps we won't have need for human beings to work. Didn't work out that way. So the real question is, with all of these factors, what should we be expecting in terms of employment rates in the future? So much looking forward to all of your thoughts on this. They will be much appreciated.
Thank you, Steve and Karen. Now I'll turn it over to Stipza for your opening remarks.
Thank you. I hope you can all clearly hear me. As it was said in the introduction, I'm assistant professor in the Department of Health Systems and Population Health at the University of Washington and a non-resident fellow at the Urban Institute. And my research focuses on broadly studying the economic well-being of older adults, and obviously labor force trends at older ages are an important element of it. So in particular, in a recent study that I did with my colleague from the Urban Institute, Barb Butrika, we explored the relationship between the evolving nature of work and health, work-related disability, and disability applications through its impact on job demands. And in this research, we used data from the Health and Retirement Study alongside information from the Occupational Requirements Survey and the Occupational Information Network. So first, I'll talk briefly about some of the findings from this research and then try to link them more clearly with the main takeaways in the context of our discussion today. So we found that job requirements, in particular as they relate to work flexibility and physical demands, are an important determinant of disability applications, even accounting for various personal characteristics. And our findings suggest that Americans are increasingly working in jobs that require more education, experience, and training, but also offer more workplace flexibility, whereas environmental conditions and especially physical requirements of jobs are arguably becoming less challenging, at least on average. The relationship between health status and disability applications partially varies by job demands, and that relationship is also changing over time. So, for example, the positive relationship that we find between having multiple doctor-diagnosed health conditions and disability applications is attenuated as job flexibility increases and then gets amplified as physical job requirements increase. Importantly, those that are applying for and receiving DI benefits come from an increasingly select group of workers that are facing worsening job conditions and increasing work requirements. Furthermore, we found that changes over time in job demands are driven primarily by within occupation changes, meaning that the same jobs have higher requirements today than they had in the past, especially with respect to cognitive demands of jobs. So it's not only, as we heard previously, that the composition of jobs and where people work, what types of jobs is changing over time, but also the nature of jobs themselves, nominally the same jobs, is also changing even more so over time. So in the context of what we are discussing today, what are some of the main takeaways? Well, first, the changing nature of work means that an increasing share of older adults may be able to work longer if they want or need to, given that both the composition of jobs in the economy and the job demands within occupations are changing toward being both physically and environmentally less challenging. However, there are several caveats. First, as cognitive demands of jobs are increasing and dementia is increasingly recognized to be among the key health challenges facing older adults, this raises the possibility that those experiencing cognitive decline, think of mild cognitive impairment, which is sort of a first step toward becoming cognitively impaired during what are traditionally considered work years. Think of people in their 50s, in their early to mid 60s, they would face constraints in their ability to remain attached to the labor force. Also, an increasingly select group of less educated older adults is still working in physically demanding jobs, and they're disproportionately applying for and relying on disability benefits. Therefore, while the overall trends may indeed favor increased labor force attachment of older adults, there are important segments of older population that could find it hard to remain in the labor force at older ages. This is important in as much, quote unquote, simple solutions such as increasing the retirement age across the board obviously are never that simple and can really work for all only if designed in such way not to penalize those older adults who, through no fault of their own, simply cannot continue working beyond a certain point in their lives. Now, while I do consider that the results that I was just talking about may have some relevance in the context of thinking about the future of work, they are to some extent incomplete as they primarily focus on the supply of jobs in the economy and supply of older adult workers, but fail to recognize the importance of hiring process and any possible barriers that older workers may face in it. And in fact, in another study that I did with Barb Butrika, we focused on examining skills-based hiring process and trends for older adults. And we found that older adults do continue to face age bias in hiring, often motivated by long-held beliefs that older adults are unwilling to or incapable of adopting IT skills needed for job performance, that they are less flexible than younger workers, and that they may be comparatively too expensive. However, while these stereotypes persist, we also found that there are positive signs of employers increasingly valuing the experience, job-specific skills, and work ethic of older workers. Interestingly, increasing appreciation of older workers seems to coincide with a general aging of the workforce, including managers making hiring decisions. So flexibilization of work and increasing availability of part-time and remote work, which were already underway, further accelerated during the COVID-19 pandemic. And also there has been a general shift toward more of skills-based hiring. And this seems to be an overall positive for labor market prospects of older adults. But again, those benefiting most from these trends are experienced professionals. So there's a little bit of that, again, that story of bifurcation where there are increased opportunities for some, but then also a group that is still being, so to say, left behind. And so just a couple of concluding thoughts. I would like to say that, speaking more generally, the change is permanent and inevitable in all human endeavors, including in how we perform work. So in that context, we need to be ready to embrace it rather than fight it. Indeed, the changes that we are already witnessing or about to witness in the coming years are something that, while inevitably bringing disruption, could also provide enormous opportunities for improving the well-being of older adults and society more broadly. So to put it simply, in a world where human capital, I think we would all agree, is increasingly scarce, there is really no justification for wasting any of it. So I will stop here, and I want to thank you for your attention. I'm looking forward to the discussion. Thank you.
Thank you, Stepika. And next, I'll turn it over to Stephen.
Thank you. Thank you very much for the opportunity to present today. Look, I have no particular expertise on the future of work. The people joining me on this panel have much greater insight into this than I possess, but the remarks I want to leave you with certainly are appropriate for a day devoted to discussing the uncertainties surrounding the future of work, as well as the future of mortality and disability, the core issues of OASDI. The task of the Social Security Administration is not that of engineers building a bridge. SSA and its analysts need to account for and respond in much greater degree to the presence of uncertainty. Not all uncertainties are created equal. For some, we can use probabilities to account for possible vagaries in future conditions. Many of the uncertainties that SSA deals with are demographic. How many 65-year-olds will there be in the United States 20 years from now? Well, that's uncertain. Small changes can bring large changes, large effects over time. But we know that those who reach that age in that year are currently alive today. How many will take the 65-year-old or 66-year-old payout when they reach that age? Well, that's a bit more problematic, and why we're interested in the future of work. The Social Security problem is an example of a larger class of problems, those requiring analysis of policies that play out over the long term. And this can bring in yet another form of uncertainty, what has come to be called deep uncertainty. Deep uncertainty exists when we cannot adequately characterize uncertainties by probabilities because, well, those turn out largely to be just another category of conflicting assumptions. Deep uncertainty exists when we do not know or we cannot agree upon the probabilities attaching to future values of important factors, or we do not know or agree upon what are the causal mechanisms that lead to different outcomes, or call it deep controversy. We do not agree on the normative basis for assessing future outcomes. How much economic growth do we want versus environmental sustainability? So the presence of deep uncertainty takes analysis designed to support policy planning and decision-making out of the realm of the predictive analytics, or at least it ought to. The paradigm of engaging in the best forecasting that money and analysis can provide, and then optimizing a decision around one or a group of forecasts, leaves the resulting decisions all too brittle and subject to surprise. Yet, if law or regulatory practice requires this predict then act process to occur, it leaves the analysts with little choice in the matter, and policy planners, on the other hand, are left underserved. What I and my colleagues have learned in taking on policy problems characterized by deep uncertainty is that we should take the same models and the same data that already exist within agencies such as the Social Security Administration and ask a different set of questions. Today, we ask of data and models and analysts the question, what is likely to happen? What will be the future of work? But is that even really the right question? The question that we would truly like to have answered is, given that we cannot reliably predict what will happen, How can we best choose among available short-term actions so that they will be consistent with long-term goals across many potential futures? And I would submit that this question really lurks behind most requests for forecasts. So why not address it explicitly? Analysts face difficulty in providing definitive forecasts to policymakers as the time horizon lengthens. There's also often a quiet disconnect in meshing the styles and requirements for rigorous analysis with the needs and language of legislators and decision makers. How can the deductive logic of analysts best support the more inductive logic, the logic implicit in what if conjectures and narratives that are used to plan and implement policies? Over the past 20 years and more, a widening group of policy analysts have developed and applied a series of methods designed to support decision-making under deep uncertainty. The methods share certain attributes that should be of interest to the leadership of SSA and those charged with conducting analyses in its support. I'll just run through these very briefly. The purpose of analysis is shifted from the current project of determining which set of currently unknowable assumptions is likely the more accurate. Rather, the analytical resources are used to search for, assess, compare, and stress alternative solutions, alternative policies over a range of assumptions. And an important result is that the policy body itself is brought into the analysis in the very terms used in the policy discussions, which relieves the burden on policy planners for themselves deciphering what importance analytical results might hold for their deliberations. Conducting an analysis with a broad range of plausible assumptions from the onset goes quite a way towards deconfliction over interests, viewpoints, and equities. All are along for the ride. It's no longer that one needs to be wary of the initial assumptions that will then drive the final results. And rather than being forced to determine ex ante what scenarios are important for understanding choices, DMDU methods instead derive and illustrate important scenarios analytically. By important, I mean an important scenario is one that helps illuminate policy choices, their potential consequences, and the key factors that should be used in selecting among them. Another common feature of these methods is that uncertainties are not characterized in terms of probabilities that often we can only weakly guess at, and the import of which is difficult to translate into policy narratives. Rather, the uncertainties are characterized in terms of the effect that they have on the choices before us and on the criteria upon which decisions should be made. And by the way, one discovers that not all uncertainties carry the same weight. I mean, to be sure, they all may have an effect on outcomes, but in DMDU methodology, we've gotten out of the prediction game. Instead, we're trying to compare choices. And routinely, we discover that only a few unknowns really are crucial for decisions on policy choice. In other words, you can answer the question, what would I need to believe is or will be true in order to recommend policy A over policy B? And finally, the adaptive approach to planning that emerges from this style of analysis should not be understood as being open-ended planning. Robustness is achieved by determining which short-term actions are assessed as being of low regret, identifying in advance signal indicators as guides to how the future may unfold, as well as what are alternative courses that would be taken in light of what is observed. at these points. So let me close by really kind of telling you why I wanted to take this opportunity to discuss this. We're at a point of transition. The challenges faced by our institutions of decision-making mean that they are no longer best served by past approaches and processes. The capacity exists for the style of analytical decision support that I described, and that I would suggest is better suited to the complexity of the challenges being faced by the institutions of democratic governance. Well, this is not necessarily the way things are done in Washington. There is something of an unfortunate cycle of policy planners and decision makers asking for only those analyses that they believe are feasible and reasonable to ask for, or are in accord with existing law and regulation. And analysts are then forced to conform to the narrow questions being asked of them. I would hope that we could perhaps take a step back and consider what the means we now have available could do to resolve some of the fundamental questions that lead to the sessions that we have had today. And with that, I'll thank you.
Thank you, Stephen. Now I'll turn it over to Shelley.
Thank you all so much. And in some ways, I think I'll build off of some of these ideas around deep uncertainty and hopefully provide at least a few more answers than additional questions. I'm Shelley Stewart, she, her pronouns, and I currently direct the Future of Work initiative at the Aspen Institute's Economic Opportunities program. And first of all, thanks so much for the opportunity to engage in this conversation and be here today. And I'm kind of generally considered an expert on the gig economy, platform-based work, and how those types of arrangements reflect and impact broader labor market challenges. But my own research within the discipline of sociology started much more broadly. And I'm actually going to start there today in order to try to explain kind of how we got to this point where the gig economy is a regular part of conversations, especially conversations about the future of work. And you know, I engage in a lot of these conversations about the future of work, given my current title and position. And what I see as the defining trend of the labor market and the direction that we're headed is not about app-based gig work. It's not about automation displacing workers. It's not about generative AI and ChatGPT reshaping different types of work. It's about a shift of risk. And that's been going on for about half a century as the risks of labor, of work, increasingly fall on individuals, on workers in a wide range of industries going about their jobs. And I push back a bit against describing this as kind of the changing nature of work, because that can, you know, come across as kind of this intrinsic aspect of the work itself, but it's really the changing nature of work relations. You know, it's not intrinsic, it's not technologically driven, although new technologies do facilitate it in various ways. It's more the result of shifting norms of business practice and of decision-making, both within business and within policy, where labor and work is seen less as kind of the driver of the economy, the source of profit, and more as kind of an expense to be cut by the business in the name of the bottom line. And this manifests itself in several different ways. And one of them is that it makes it harder to make trends. And this is where this intersects with a lot of what Stephen was describing. You know, in this world where risks are increasingly on borne by individuals, people's careers are up to them. So rather than a system of long-term employment being rewarded with pension plans, our economy is set up to incentivize job switching, to maximize income over the career in order to build wealth as an individual, which takes on that risk and also prompts people to move around. We also see a rise in contracted work arrangements, which take a wide range of forms across a really wide range of industries. So we may hear about this most commonly in terms of app-based independent contract driving. This is your Uber, your Lyft, your DoorDash. We see it in the rise of non-tenured adjunct teaching at universities in relation to tenured professorships. We see it in the way that physicians shape their contracts with hospitals. So this is not just among lower wage sectors. We see it at the gym as personal trainers take on individual clients rather than being employees of the gym. Somewhat ironically, HR work can now be contracted out. So rather than hiring an HR person or department, small and mid-sized businesses can contract that out to a different company that manages the HR functions of a whole wide range of different companies. And there's a lot of different implications to these trends, but one to start with is how hard it makes it to project into the future, so long as this is happening, because it puts a lot of the decision-making about work and about labor in the hands of the workforce, rather than in the hands of employers. And employers tend, this is a generalization, but they're more likely to act predictably, to follow trends consistently, to kind of play by the rules of economics, at least to some degree. Where the workforce itself, the people who make up the workforce, are much more diverse, have a much broader set of goals and of priorities. And so the overall trend of shifting risk is pretty well documented. It makes predictions as to what that means and kind of how it shapes our future even harder. So questions like, if people are going to work, how people are going to work, how long people will work, when that's shaped by individual incentives and decisions and positions, it gets harder and harder to predict that as change becomes more and more likely. So with that kind of said as the foundation, we can think a bit about what are some of the implications that we do understand. What is this so-called gig economy, and how does it impact how we think about work and workers going into the next few decades? And with this term gig economy come a whole range of definitional challenges. So for some, it means specifically the app-based work, the Uber driving, the DoorDash delivering. And for others, it's kind of anything falling outside of a long-term, permanent, full-time employment arrangement. And kind of somewhere in the middle is a pretty broadly used definition, which is the one that I'll be generally referring to, which is work that falls outside of full-time, long-term, direct hire employment. It's not a great definition because it is an everything but sort of thing. It encompasses a wide range of things outside of that one kind of normative paradigm of what work can look like, to include a whole basket of other things. So, the term has grown in its use with the rise of app-based and task-based work. This again is the Uber and Lyft driving, but it includes independent contracting, freelancing, short-term work, seasonal work, project-based work. By sector, it's a lot of arts and cultural work. It's almost all domestic and care work. And these jobs have existed as long as work has. In fact, much of it predates what is considered to be this traditional paradigm of work. But it's an othered type of work because policy and measurement have been built around that traditional paradigm through the middle of the last century, looking to what workers, which is predominantly white male workers, were doing, it is employment with a firm over a long-term direct hire work. That's how we tend to measure work, and that's how we tend to design policy, and our programs are still designed for those types of work. And so when we think about how many people are really engaged in gig or non-standard work, the measurement is tricky because of that reason, because of how our tools were designed. Most reliable, valid measures, these are the ones used by census, used by BLS, were designed around that work and do not always reflect gig type work arrangements. We see that reflected in kind of wildly conflicting estimates. You'll see numbers from, no one is doing this, it's less than 1%, to everyone is doing this, it's going to be 2/3 of the workforce by 2050. And a lot of those differences are also rooted in the different definitions that people are using. So we have these kind of two competing factors, or two coexisting factors, that explain why in some ways we don't have a great idea of the wide range of ways that people are working. That all said, taking into consideration those challenges, when the different measures are standardized, when definitions are kind of evened out as much as possible, about 10% of the workforce relies on these different types of non-standard work as a primary income source, so as their main job, and an additional 10 to 20%, although this number is fuzziest of them all, use it to supplement another income source, most commonly a more traditional job. And that piece, that very uncertain portion of the workforce that is using gig work as a supplemental job, is kind of the focus, or where I want to bring the most attention today. Again, unsurprisingly, and a common theme, there's tensions with multiple job holding data as well. Current population survey shows some decline, but that definition is generally considered to be particularly likely to miss gig work because of the time frame used for that. And gig work is often taken on pretty sporadically. So if you're asking people what they did last week, it's highly likely to miss whatever gig work they may take on over the course of a month, much less 6 months or a year. If you look at census longitudinal employer household dynamics data, there has been an increase in multiple job holding. Again, that is likely to miss a lot of the gig work. But that over the last 20 years has shown an increase from about 6.8% to 7.8%. Not a huge gain, but still a noticeable increase. And looking at tax return data, there's even a steeper increase of people earning secondary income from a second job. And that is especially independent contracting work, and most especially the biggest increase in the major app companies that we commonly think of. And so when we think of supplemental work, there's a piece of this that is kind of cultural, that's a trend towards how can we monetize our time. I'm not going to have knitting as a hobby, I'm going to knit hats and sell them on Etsy. And that is a piece of what's going on here, but there's a much bigger issue that is financial necessity. When wages have not kept up with the cost of living, especially major expenses of housing and education and medical care, one job is not enough to stay afloat for a lot of people, and retirement savings as people get older are not enough to live on. And we see the biggest increases in this type of work, and this is on some private surveys, but especially the tax data again. The biggest increases are among populations that do not fit into that traditional work paradigm, which at the time, systems were designed were primarily mid-adulthood white men, and continue to be so. But we see increases among older workers who may not wish or not be able to work full-time, but don't have enough savings or retirement income. So they pick up gig work to supplement that. We see it among workers who are balancing caretaking commitments, whether that's of children or parents or themselves, and who are unable to take on the rigidity of many traditional employment schedules. We see it among workers locked out of employment systems due to former incarceration or lacking a stable address, and among people across all demographics for whom today's low wage, low agency jobs just aren't enough. And the opportunity to work for a lot of these people is welcome, and the broader labor market could learn from the relatively low barriers of entry, but it also introduces a kind of gray area of work, which is work that exists because other systems are failing. So we often hear about the changing nature of work as it relates to the gig economy as a rise of gig type arrangements, and less about sort of the why behind that. And so the conversation needs to address the whole picture and not just look at gig work existing in isolation, but as part of an entire trend, again, back to the shifting of risk, and the stagnation of wages in relation to both productivity profits and cost of living. So it's not, a trend in isolation or an inevitable reality, but it is something very real that we need to be thinking about and grappling with. But we can't just look at gig work. We need to think more broadly what's happening in the labor market that is driving people to this, and how can changes to the labor market overall potentially change the way that we're thinking about and projecting reliance on gig work as well. So I will stop there and look forward to some conversation.
Thank you, Shelley, and thank you to all of our panelists for those wonderful presentations. First, I'd like to turn back to Steve and Karen and see if you have any reactions or questions for the panelists based on what we just heard.
Thank you, Emily. Let me offer a couple. First of all, talk about a wide diversity of breadth of thought here. This is really just exactly what we were hoping for in this kind of a panel. Let me just react to one thing that Stephen Popper mentioned, which is deep uncertainty. The good news is that the charge for our trustees that we in the Office of the Actuary work on for providing the annual trustees reports has a very simple ask. It is, what is the actuarial status of this program? It's nothing terribly specific. And as a result, we are able to take into account anything and everything related to deep uncertainty. And that is, of course, why our friends with the SSAB staff have helped us put together this discussion with you all today. We are not really dealing with the narrow questions. We're trying to get a good overall sense of what's happening with the society and the economy going forward to help us in assessing where we will be under current law, Social Security, and what the implications might be for other changes. Now, Stipika, thank you so much for sharing about sort of your sense of sort of where we're going with capacities of people having into the future, the kinds of changes in what is being demanded in work. We have seen tremendous increase in educational status of the population over time, many more people, which does fit. Now, whether that's a driver of or just as accommodating the changing occupations towards more needing education, less physical, not entirely clear, but we certainly have gone in that direction. So it's positive to see that we're going to be there and likely probably staying there in the future. Shelley, you're talking about the shifting of risk. I have to share with you, and I know you all are very well aware of this. One of the places we as actuaries first saw that was in pension plans provided by employers who were hiring people for a lifetime of work, when they shifted away from defined benefit plans to defined contribution plans, expressly with the notion of de-risking, which is really, as you well put it, it's shifting of risk. We've also been very conscious for a long time now, people working in the self-employment sector, that based on the best data we have available, a shrinking share of work in independent contractor self-employment actually is being reported to the government for tax purposes. And the sad part about that is, if it's not reported and people aren't paying payroll taxes, they will not be getting credit towards Social Security benefits. And so what is their plan then for where they're going to be in the future? The other thing about the gig work, something I think we've all been much exposed to, it does not appear to be all just a matter of people having a regular job and then having a gig work as a side hustle, as some people like to put it. But rather, in many cases, it's something where people has, as I think you were alluding, Shelley, 2 or 3 gig work jobs, which part of the de-risking by the employers is if you're working less than a certain number of hours, then benefits may not be forthcoming. And so this presents with us a whole set of uncertainties of people in the future not having employer provided help when they reach into retirement. But at least, hopefully, if all this gig work is in fact reported, payroll taxes are paid on it to Social Security, at least they'll have coverage for the combination of all that work in the future, which is really what we're looking at. So just an immense breadth of uncertainties. And if you all could be a little more specific on telling us exactly what you think the path is, most likely the median, Stephen, what do you think? It's we know that uncertainty is huge. And by the way, let me just mention, in our projection models, we do not just have deterministic best estimate, although that is what is most cited. We also have sensitivity analyses for changing one parameter at a time. We have a stochastic projections, which show a dramatic range in all aspects. And also our basic projection isn't just the intermediate. We also have a high cost and low cost. So we're very well aware of variation, but I will have to share with you, and I see Amy coming on camera, and she knows it well, having worked on the Hill, that ultimately policymakers in the Congress, they generally do have a simple question: what's your best guess? We'll act on that. So we always try to keep attuned to the uncertainties, but thank you all for raising all that. Karen, did you have some further points you would like to raise before we get to Amy, Nancy, and others?
No, nothing at the moment. I will be interested. I would like to hear from the board members first. I would be interested in hearing a little more from Stephen, because I think what you're saying is you just think we should be approaching this a completely different way. Like the framework of what we're doing just should be approached completely differently. And I think I have not quite wrapped my head around that yet. So I do want to understand that a little bit better before we end. And maybe Emily, maybe now is the right time to ask that question.
Yes,
now that I
Stephen,
put it out there.
do you want to weigh in now? Oh, Stephen, you're on mute.
Stephen, you're still muted.
Okay, sorry. I've got, I did something when I was looking at the questions that didn't allow me to come back. Yeah, I'd like to address a couple of points that Steve raised. And, you know, I appreciate the nature of the work that is done. I mean, as I've expressed previously, I mean, the quality of the analysis is superb, and you know, the quality of the analysts, you know, is justly renowned. So, you know, the problem is not that, you know, people are doing things wrong. The problem is sort of pointed to by a couple of the things that you said, Steve, which is, you know, you are essentially asked a relatively simple question that can be answered a number of different ways, but it's constrained by, you know, being consistent with current law, where we will be under current law. And you also mentioned doing sensitivity analyses, which is, you know, as we understand, is certainly best practice for the type of analyses that I've characterized somewhat crudely as predict then act. The problem with both is that it leaves you looking at a relatively small point, or if you do sensitivity analyses, a sphere, a relatively small sphere in the larger uncertainty space of plausible futures. And it leaves unexplored all the rest of that space. You got the point estimate or point estimate with sensitivity analyses, and it doesn't describe a space in which the principal business of Washington can occur, that being politics? What's the trade space within which analysis suggests that you could change things like COLA rates or FICA rates or general fund revenue transfers or other changes in policy, and still be within that space that the analysis suggests means that you would be consistent with your long-term objectives. So in an analysis of the type that I describe, and I hope this helps out to some extent, Karen, might be to look at those parameters of policy that I just described. Look at the range of where you think the policy debate is over COLA or maximum salary level subject to FICA or whatever. And tell the computer in which you have placed the exact same model that you work with or series of models, show me 20,000 different policy portfolios that take different points along these policy dimensions. Just choose them randomly using some kind of a uniform sampling process. And now let's compete those policies across a range of alternative futures described by the range of assumptions over things like retirement rates and the sort of things that Shelley was describing, the demographic and work behavior and so on. And let's see which of those policy portfolios seem to be successful according to this range of criteria that we have set, that ultimately would be set by policy. And now let's look and see which one of them seem to be more routinely successful, or what elements of those packages look like they would be more routinely successful. And now let's kind of put together a different, let's call it the proposed policy package. And now let's throw it everything but the kitchen sink at it. Let's explore the full range of assumptions and uncertainties and understand what are the scenarios that would be stressful for that set of policy packages. Anyways, I won't go on in any greater detail. The point is, to do a greater examination not only of assumption space, but of policy space. And that's, I think, at the point where the people who sign your paycheck might get a little bit nervous.
So, Stephen, let me just offer very quickly. I think I have some very good news for you. Yeah. While we in the Office of the Actuary and also our trustees do not and are not charged with putting forth what we think would be the best policies for making change, we have 535 other people in the DC area whose job is exactly that. Right. They come forth with ideas all the time. And if you want to look a little pitch here, if you want to go to ssa.gov/OACT, look under provisions, you will see somewhere on the more than 100 provisions that have been put forth covering the broad range you just described of different kinds of policy changes, whether it be retirement age, to what level should we be paying taxes, what should the COLA be, covers all of these areas with estimates of where that would take us. And all of those estimates could be applied relative to not only the intermediate projections, but also if you think we would be in a different space on any of the assumptions. The only other thing I would suggest here is that we are not in the business of prediction or forecasting. We never refer to our projections as that. All of our projections are purely on the basis, and I know, Nancy and Amy and everybody else on the board are well aware of this. They're all projections under a specific set of assumptions, which are laid out very, very clearly. And that's why we have a range of different scenarios that we haven't provided. But if you're looking for policy alternatives and what they might do, please visit our website. You'll see a bunch of them, all generated by our members of Congress that we've developed estimates for.
The only quick rejoinder I would, and I welcome that. And the last time I looked seriously at SSA policy analytics was 15 years ago. So everything that you say is good news. The only thing that I would offer in response is that, you know, it's the simple models that drive policy discussions. You know, FDR was a genius at creating the simple model that would put in people's heads different pictures. And the simple model that is used now is, you know, the Social Security Trust Fund is going bust, you know, in 2033. And what I'm suggesting is that, you know, it would be useful to provide, and I'm not saying that this is anything you guys have not figured out already. It would be useful to provide those 535 individuals with a relatively simple explanation of, you know, here's the available trade space. Have all the politicking you want, but anything outside of that space, and we cannot be as comfortable in telling you that you will be consistent with the long-term goals that you have expressed. At any rate.
And so let me just ask you this.
Steve, can I just, sorry to cut you off. I just want to make sure the board members get a chance to jump in with their questions. I know Amy has a question, so Amy, if you want to go ahead.
Awesome. Thank you, Emily. And thank you, Stephen. Really an interesting discussion here. I wanted to shift our conversation a little bit, recognizing that this event is really thinking about technical assumptions. And certainly there are lots of ways to do forecasting, projections, whatever we want to call it. But I saw in the chat that Hillary Waldron asked what I thought was a really interesting question. And so I wanted to pose it during my time. And so I'm just going to read it verbatim here. How does the panel think the nature of the Great Recession and pandemic recession affected the labor market and its composition in those years? Should we think of a time series in those years as representative in a 75-year framework, or alternatively, should we adjust for a big financial shock recession and a pandemic shock recession? And if so, how? And maybe, since it's such a big question, maybe Steve, if you want to start by just sharing how you all have dealt with this in the past, because certainly you, in your data, have the Great Recession already in there for the trustees' reports.
And Amy, are you referring to me, Steve?
Yes,
Okay.
you, Steve, is the expert on all things trustees' reports.
Well, hardly that. No, we have multiple Steves, very common name in our baby names lists. But you know, with respect to the Great Recession, one of the things, I mean, Karen showed so nicely in some of our slides that while it took a decade to recover in the employment sector from the Great Recession, it took less than a year really to basically fully recover, interestingly, from the 2020 recession. So the resilience of the economy is not a certainty. We have to be careful in our modeling to assume that if we develop a model based on experience over one period of time, things will always be the same in the future. I'm not sure if exactly, I wish Hillary were here with us right now so she can restate for herself. But if what we're talking about is the idea, have we outlined the economic cycle? No. There will be economic cycles in the future, and that will have implications. What the implications of each and every economic cycle have on us is not clear. The 2020 so-called recession was coupled, of course, with a pandemic. And so we had a combined effect of those. And that's what I think really that Stipika was talking a lot about, and many other people today, about the changing nature of work becoming more virtual, as we are doing today. And I guess the big question is, how much will that stick in the future?
That's super helpful.
Will we revert?
I think part of what the question was asking was about how the workforce composition was different during those time periods. Do we know that in the data at this point?
Well, we do a little bit. If we look at it in terms of the very first slide we had, we were showing the change in the distribution of employment by occupation. We can see how that has been happening over the last 20 years. And I think what we have seen, particularly in recessions, is that we have a temporary, I mean, obviously in the pandemic, We lost a lot of people from employment temporarily in the service sector. People weren't going to restaurants, but it appears as though that is coming back. We also lost a lot of people, it seems, from some service areas working for shall we say, consumption item distribution, as in Amazon. I don't know if I'm allowed to say that, but we've seen really sort of a change. Are people going as much to big box stores as now having things delivered? And the question is that temporary, or are we going back? And this, I think, really speaks a lot to what Shelley was talking about the changing nature of work, like the gig economy. Is this a one-way street? Is it going to be ever more so? Or is this really more like a sine wave going back and forth? And I wish we had good answers on that.
That's really helpful. And I'm glad you mentioned Shelley. Shelley, would you mind chiming in here?
Yeah, I mean, what we've seen from the pandemic in terms of gig work, and I would say enough time has not gone by to see really what the impacts have been, is that there was a pretty sharp increase towards the start of the pandemic. And this is, it's logical when you think about it. Huge numbers of service sector people were not able to work. A lot of people were turning to apps to get food delivered. Those people stepped into those jobs. And what's happened since is it's spiked and came down, but it is still higher than pre-pandemic levels. And it's, still too soon to know if that will continue to decline. But if long-term trends tell us anything, it's sort of a jump up that will persist.
If I can jump in on Shelley on that point, and it really picks up something Steve just said, and that is definitely, I'm so glad you've brought up risk shift, and it definitely is a very long trend starting in the 70s. But the question is, will it continue, or will there be a pendulum swing, and or a sine wave, as Steve put it? And I think what's missing in some of the parts of this discussion is government. We had, before the risk shift, we had government, we first of all had an employment system where families got their health insurance, their retirement security, and so forth through work. And then in the 30s, we had minimum wage, maximum hours. We had unemployment insurance and so forth. And as we had increasing regulation, ERISA came just as that shift was going, and that was part of what put the nail in the coffin of defined benefit plans and shifted the risk that way because of all the employer fiduciary responsibilities and so forth. And a lot of the gig economy, a piece of that, of course, are the change from W-2 workers to independent contractors and getting out from a lot of those regulations. There, as you know, there are a number of lawsuits that have been brought to talk about misclassification, but beyond that, there's talk in both the states and in Congress of requiring this mislabeling, or even if it's correctly labeled, putting more requirements on those who've been are treated as independent contractors. If we got even an expanded Medicare, lowering the age to 55 versus even Medicare for all, that would make a huge impact on employment and people's employment opportunities. So much of wages now go to paying non-cash, so forth. So this is sort of a long way of saying Congress is taking note of some of what's going on. I mean, there is a lot of talk about the shift to independent or mislabeling of independent contractors, talk about expanding Social Security, talk about expanding Medicare. And that may, I guess the question is, will that reverse some of this trend, or you think it's just, it's a railroad going down the track and it's just going to keep going down? So that sort of whole range, government's role and government's changing policy and what impact that has on all the issues we've been talking about.
Yeah, I mean, I'll jump in to say that it was government action and especially inaction that has got us to where we are and could just as easily stop and reverse that trend. I think whether or not that will happen is anyone's guess. I think there's definitely potential. This is in no way inevitable. And I think I mentioned it's also not driven by the technology. It's driven by decisions made by people in positions of power, both in government and in business.
Well, it is the deep uncertainty with what Congress will do.
Bob here. I was going to jump in on this and pick up on what you said, Shelley, because it seems to me in Steve Popper's suggestion that we sort of open up all questions and look across the board. It ultimately comes down to policy. And right now we're having this enormous policy debate in this nation about what the role of government should be and what the role of the whole system should be. And I'll just emphasize, I just go immediately to the idea that right now we have a system in place, and then we have efforts to underfund the system operation so that it can not work at peak efficiency, is the way that I would put it. So what we have now embodies this tension. And by the same token, I know in listening to you, Shelley, as a student of history, I don't think of this as a new phenomenon in terms of how workers are treated. I think of it as a return to an old relationship between workers and employers. And so I think of it as a broader cyclical thing that is driven by policy and ultimately by the voters. So I know the work that Steve's office does works within a template, it seems to me, of a system that was put in place. And opening up a broad range of assumptions seems to me to be, I know we've got AI now and very powerful computers, and maybe we'll be able to develop analyses that go far beyond what we can do right now, but I don't see how we do that. So I guess I'm questioning how we can really throw all those assumptions open and hope to arrive at something that we would all agree is workable. Okay.
If I could offer one small thing there relative to what you just said about Stephen. One thing we have found over all the years is that there's been some resistance, and I mean, Amy and maybe some others could speak to this, some resistance in Congress from having sort of automatic adjustments on things, like automatic adjustment on the retirement age for what's going to happen with there's more of a desire to say, no, we want to specify this in law. And to the credit of members of Congress, when we've talked to them about this, they said, if it doesn't work out, we can always change it. And that is so true. A law is nothing but a statement of intent by that Congress, and the next Congress can change it. So nothing is absolutely set in stone. Amy, please go ahead.
Yeah, I appreciate the call out, Steve, and certainly plenty to discuss here. Though, as I'm thinking about the point you're making, wanted to circle back to a question around, what does this all mean? Because ultimately, you all need to take the information that we're getting here and put it towards the assumptions going forward. So I'm curious just how this panel thinks how the nature of work might evolve to encourage people to work at older ages. Because we talked about mortality this morning and how some folks are living longer, though there's some changes in the composition there. So would love to hear from our panelists about how they think, especially Shelley with the gig economy, if that's something that might allow for older ages.
Yeah, I think there's kind of a few ways to think about this question. And one is the necessity piece. And gig type jobs are available to almost anyone. And if you do not have enough income to live on, regardless of age, that becomes a very viable option. There's another side that is about accessibility and kind of allowing access for people who do want to work and for whom a more traditional arrangement may not be appropriate. or feasible. So there's, the gig economy provides both. And because it can be available, it also should not need to be used by folks for whom it's the only option.
So Pizza, I wanted to see if you have anything to add there too, because I know your work focuses on employment at older ages.
Yeah, so I mean, and before doing that, if I can just go back to earlier discussion, we talked about recessions, right? And Great Recession and pandemic and what impact it has on the long-term impacts. And I would say that often what happens with recessions is that they accelerate already existing trends. And so flexibilization of jobs, the availability, to work remotely, etc., it already was on the rise, facilitated by technology that was being developed. It just got turbocharged during the pandemic because of the need. Now, to what extent that may get scaled back, that's a question. I mean, we see examples, we see companies like, I believe it's Goldman Sachs, that is trying to get people back 5 days in the office. We see others that are going a different route, and especially tech companies letting their workers to be fully remote. Urban Institute, for example, they also allow people to be fully remote now, whereas before pandemic, people were allowed to be, up to 2 days per week. So some things got accelerated, and I think that's generally a feature of many recessions, that things that were already underway get accelerated, as opposed to really making this dramatic change of reverting back to something that was decades ago. That usually doesn't happen, right? So I think it while we don't know, each recession is unique. It happens for different reasons. Those black swans, they're called black swans for a reason. While we don't know that, we may have some sense of how things may play out based on what caused the recession, and then that can give us some input for assumptions that would be built into the projections. Going to also in terms of the labor, part of it is how much employers need people with certain skills, and that ultimately affects the negotiating power. And it's not a new phenomenon, that's been there forever. And we've seen recently also a little bit of a resurgence, maybe it's here to say, maybe not, of organized labor. And so between those trends, there may be changes in the future. And in that regard, I think, especially with respect to projections, and the future of work, I think it's inseparable from immigration because of the importance of immigration for this economy. And thinking about what is happening globally. And globally, basically, you have an increasing number of countries with declining fertility. The pools of really qualified labor are being exhausted. So any kind of assumption that would think of immigration as something that can be switched on and off is sort of fool's errand, because there simply is a decreasing number of available people in the world that could fill the ranks of the types of immigrants that the economy would potentially need, which then impacts what I was talking about, negotiating power of workers vis-a-vis employers. And so those kinds of things, I think we can talk about some level of certainty. We see those trends to be pretty inevitable, at least over the next several decades. And so I think those are some of the things that could feature importantly, right? And then Amy, can you remind me of we were talking about the question you had specifically?
Yes. So the question I asked was around how the nature of work was evolving and might encourage people to continue to work at older ages. And so Shelley was able to share a little bit about the gig economy.
Yeah, so I mean, what we've seen is generally that the types of work requirements for different jobs have been changing, both within occupations, and then there's a compositional change. And so basically jobs are becoming increasingly cognitively demanding. But generally speaking, the physical demands on the jobs are becoming less prevalent. And those types of adjustments generally favor the ability of older people to remain longer in the workforce. Now, that can also that has to be looked in conjunction with health trends for older adults, because it's not only about the requirements of jobs, but it's also about how the health picture of older adults looks like. And that's where the issues regarding cognitive health may become relatively more important than issues of physical health, which used to be the dominant. And now there's a little bit more of a balance of the importance of physical and cognitive health for the ability of older adults to remain attached to the labor force.
Thank you. Jagadish, I wanted to see if you have any questions for the panelists.
Well, I don't know if I have any questions. I do have some observations. I don't know if maybe I'll be short. This session was on the future of work, but a complementary session should be on the future of pay as well, because you might work a lot of hours, but if you don't earn a whole lot during those hours, then this still has implications for the size of the payroll tax base going into the future. And that has a lot, the salient issue there is the labor share of output and the adoption of labor saving versus labor augmenting technologies in general. That's a whole different discussion, but we need to get to the bottom of that as well if you're going to talk about projecting the payroll tax base, which is ultimately what matters. That's my first observation. The second observation is someone mentioned that the job flexibility and more supply of jobs, especially gig work and so on, better accommodations by employers in jobs are good, but they have differential effects across workers of different types. Much of the benefit may be accruing to educated workers who can work longer, have desk jobs rather than physically demanding jobs and so on. But my observation would be that the disparities in how these different amenities in jobs affect different types of workers occur not just across education, but across many other different attributes. And in the morning session, there was some resistance expressed in terms of how disaggregated our modeling must be in terms of not just the incidence of different health outcomes, but also different sources of disability, but on the types of people that are exposed to the risks of those alternative health outcomes and disabilities. So I would still make a pitch for a more disaggregated set of projections, which will then add up to the baseline projection that the actuaries make. And there does not seem to be any, in principle, any objection that could be levied against a micro-founded set of projections that would help inform the trustees and policymakers in general. And a final observation is that we are talking about, employers de-risking and engaging in more contract work into the future. A single observation that I would say is now over the last, 50 years or so, we've seen government expand all sorts of social protections, food security, SSI, disability insurance, health insurance, pensions, and so on and so forth, which have served to de-risk for workers, because they now have all these sources of support to fall back on, which may then trigger their preference for more flexible work, because they now have the source of fundamental source of a social safety net to fall back on if things should go wrong, and they periodically might go right. So workers' preference for flexibility may be one thing underlying the reason we're seeing more people engage in gig type work. And the point that you have to fall back on this work and take 2 or 3 gig jobs in order to make ends meet. Well, the other side of the coin is, thank God the jobs are there, and that happened because of technological progress and adoption and better information technology that makes these communications channels possible, so that we can have Uber and Lyft and DoorDash and types of work possible in the economy, which helps people make ends meet. So there are, the meta message here seems to be that government action to reduce the amount to de-risk for workers has been met by employer reactions to increase risk on workers. So the total amount of risk that workers face may not have declined in the end. You can poke a balloon on one end and it pops, it inflates further on the other end. Is the kind of thing that I see. So people talking about the pendulum shifting back and forth. I think the pendulum is here to stay as long as we have a pretty robust social safety net into the foreseeable future. Thank you very much.
Thank you. I know we're just about out of time. I just wanted to quickly see if any panelists have any final thoughts they want to add before we wrap up.
I can maybe take a minute to respond quickly to what I understood Chairman Judef to be asking about, introducing more exploration of policy alternatives and so on. I mean, what I suppose I've been advocating is a technological innovation, or at least an innovation in technique, but I'm by no means a technocrat in two senses. Policy should not be decided by computers. The job of people like me is to support those who make policy and to help them better understand their choices, the consequences of those choices, and the basis upon which to choose among them. But also, in a second sense, I by the nature of the work I do, I engage in a lot of technology transfer, methodological transfer, and so on. And what I've learned is that the technical aspects are at best, 50% of the job. You have to be aware of the process, you have to be aware of the sensitivities, you have to be aware of the organization, and so on. And I guess my bottom line suggestion is that there are ways and means to perhaps gradually introduce this sort of perspective that I have been suggesting, rather than throwing a bomb in the midst of the existing policy process in Washington. I'll leave it at that.
Thanks, Stephen. Shelley or Stepizza, do you have any final thoughts before we wrap up?
Well, I'm not sure if I have really, super insightful final thoughts, but I would say on the, from the existing evidence that we can say that in terms of older adults, we can say that their future is potentially bright. Obviously, there are always issues that can, we don't know what the future holds in terms of unexpected events, but from some reasonable assumptions, we can say that we are going toward the world, I think, where an increasing number of older adults will have the opportunity to work if they wish so. Now, that's different from those who might be forced to work because they have to. And that's where, we just need to be careful in how we approach the two groups and who are in two groups, and also then the third group of those who may wish to continue working or would need to continue working but cannot because of the health issues. And I think it's important to distinguish those groups and approach them in terms of the policy making in such way to make it fair in terms of the outcomes that they would face and supports that they would be getting. But on a broader point, I just want to say that obviously, talking about any individual aspect is almost impossible without having this broader view of all the trends that are happening simultaneously. And that's why I really commend you for that approach in your work. And I think that is ultimately the way forward, is to really have this all-encompassing view of demographic trends, of health trends, etc. And then those impacting, things such as the future of work. None of these pieces can be looked at in isolation from all other things that are happening simultaneously. And I think that you have that view, and I think it's important, and it allows for a reasonably useful predictions to be made that policymakers can rely on with all the caveats attached to them.
Great, thank you. Shelley, did you have anything you wanted to add?
Recognizing the time, I'll just say, I think we've raised a lot of the very key essential questions about the future of work. And there's a lot of answers that I think we'll all be continuing to work on.
Great, well, thank you so much for all of our panelists and to everyone joining us today. I think this was a really interesting discussion. And I'd like to turn it over to Bob for a few final words.
Thanks very much. And I especially want to thank our audience for engaging with us today and participating in this quite thought-provoking and challenging conversation. Feedback is welcome and desired. And if you would like to comment on today's event, please email us at events@ssab.gov. That's events@ssab.gov. And with that, one more thanks to everyone, and our day is complete. Thank you.